Good evening, everyone, and a warm welcome to today's webinar on spinal muscular atrophy, closing the gap from carrier screening to newborn diagnosis. On behalf of MedGenome, I sincerely thank all our esteemed faculty and delegates for joining us today. Spinal muscular atrophy, as we know, is a severe neurodegenerative disorder with a carrier frequency being very high as 1 in 50 in Asian population, with an estimated incidence of 1 in 10,000 live births overall. We are honored to have such a distinguished panel of experts with us to share their valuable insights on this important topic. Without further ado, I would like to invite our moderator, Dr. Seema Thakur, founder and director, the Genetic Clinic, to take the session forward. Over to you, Dr. Seema. Thank you.
Thank you, Dr. Sandhya. It's my privilege to, talk on, to hold this webinar on SMA, which is actually a very common problem of our country. And the carrier frequency, as you already highlighted, is very high. So I warmly welcome our guest of honor, actually, Dr. Sharda Jain, although she couldn't join, but she is a director, Life Care Center, and she is a founder and secretary general of Delhi Gynae Forum and North India Gynae. So a well-known figure among the obstetricians. So she is a fatherly figure for all of us. Then I would also like to extend my warm welcome for I think Dr. Sunita, she is not yet joined, but she is a senior consultant and vice chairperson at Institute of Medical Genetics and Genomics, Sir Gangaram Hospital. And our another expert for today's session is Dr. Sangeeta Gupta. She is an obstetrician and she is a director professor, Obs and Gynae at MAMC. I would also welcome my chairpersons and Dr. Shefali. She is a well-known expert in this area and whom everybody knows for her work. She is a pediatric neurologist and who has dedicated her life towards the treatment of the children with neurological disorders, and SMA being one of the close so where I have seen her lots of work done in the SMA, and today I came across one of her pioneer paper in SMA from India which is just published in July 2026. She is a professor in pediatric neurology at AIIMS. So welcome, Dr. Shefali. And another chairpersons for today's session who has kindly agreed is Dr. Upma Saxena. She is a professor and consultant of Obs and Gynae, head of unit at Vardhaman Mahavir Medical College and Safdarjung Hospital, New Delhi. Welcome, Dr. Upma. I think Dr. Dr. Jaya Chawla, she is a professor Obs and Gynae at RML Delhi. So as we all know, the SMA has been in news recently for many reasons. First is the treatment, because this is one of the few genetic disorders for which the curative therapy has been, developed. So this is in news, but the treatment is exorbitant. The cost of the therapy is very, very high. So because of the multiple social media, this has been in news because of the crowdfunding, the cost. Then recently in 2024, the Society of Indian Academy of Medical Genetics, they published a universal carrier screening for SMA guidelines which was endorsed by Society of Fetal Medicine, Foxy. So, seeing all these, and the knowledge of spinal muscular atrophy is limited among the obstetrician, those who are actually the front line for this carrier testing. So one of the reason is, and third reason is that the August is the SMA awareness month. So we thought we'll take this opportunity to, discuss about this condition. So SMA is a common recessive disorder, and the main characteristic is the degeneration of the spinal cord motor neuron, which leads to the atrophy of the skeletal muscle and overall weakness. And there is a spectrum of age of onset. SMA continues to pose serious diagnostic and therapeutic challenges. And in today's webinar, we discuss on the diagnosis, carrier screening, prenatal diagnosis, newborn screening. So now I request a word of wisdom from our esteemed chairpersons for today and the experts for today. So first, I would request Dr. Shefali. Dr. Shefali, can you hear us?
Yeah, wait. Yeah. Good evening, everyone. Thanks for having me over. SMA is a very important condition, especially in the last 2 decades. There has been so much of advances in this treatment which have come up. And basically, we have three basic treatments which have come up. But before that, you have already flagged that you have a very high carrier frequency, which ranges from 1 to 20 to 1 in 16 various studies, and which fits into the parameter for the population-based screen. Because when you talk about, you'll be talking about newborn screen. So even newborn screening, although has been started in many small hospitals and many corporate hospitals, but doing it at a national level at this point is not possible. Because I'm also in the Central Technical Committee of Rare Disease and all those committees where you take the public health cap. We can't have it because as of now, when you diagnose somebody with a newborn screening, you have to give the treatment for them. And the treatment, as you rightly mentioned, Dr. Seema, is very prohibitive, except for something new which has come. So basically, there is a SMN1 is a gene, there is an SMN2 backup gene. So three options are available very briefly in the next 2-3 minutes. One is the replacement of the SMN1 gene, which is the primary gene, which is given through the AAV9 vector, which is the Zolgensma, which is given intravenously. It was approved for up to 2 years of age by FDA and also by the DCGI in India, and up to 21 kgs by the European Union. But in November 9, 2025, because of a trial which I was also part of and which was SEER trial, which got published in Nature Medicine in November. In November 2025 itself, FDA has approved Itivisma, which is the same some gene therapy, but to be given intrathecally from more than 2 years of age to adults, to adolescents and adults the entire lifespan. So that is what the gene therapy is there, and it doesn't integrate into the human genome. It stays inside, but because the motor neurons have a long life, you don't expect that, we may need to give it repeat. And they had studies have shown that up to 7.4 years, you have the benefits remain, because the studies are only for 7.4 years. Yeah. And second one is basically intrathecal nusinersen and risdiplam, which you were talking about in the beginning. They both of them are SMN2 splicing modifiers. What happens is SMN2 is a backup gene. SMN2 or SMN1 has one difference. There is a C2T base pair change, which leads to the exclusion of exon 7 when the mRNA forms. So, but this SMN2 splicing modifiers, both nusinersen, which is intrathecally given, risdiplam, they both are acting in a different points, but both of them have the principally the same, that they are SMN2 splicing modifier. So as to put,
I think we lost her connection.
But I think she's got connected by two devices, Dr. Seema. Good
Okay.
everybody.
So now I think Dr. Sangeeta,
Dr.
you
Seema, can you hear me?
Yeah, we can hear you.
Yeah, I logged in from two devices, but I had the output off on the one because I doubted my two connections. I was using two connections. Some kids have problem. So I'm saying that SMN2 splicing modifier that takes up the SMN2 backup gene and tries to produce some functional proteins. So you have this intrathecal nusinersen and this oral risdiplam, and risdiplam is FDA approved, DCGI approved as well. And you have one generic formulation which has come up last year, which cost only 15,900 per bottle, versus the main Roche product, Evrysidi, which cost around 6.5 lakh per bottle. And that is, although we have experience with all of them, we have personally experienced with all of them, all the three, were having given 26 gene therapies and having following 47 nusinersen patients and 20 odd risdiplam with some with combination, all have shown improvement in milestones. All these children, but our problem is that all these children have been picked up late, because as the child is born, then there is neuronal apoptosis. So what degeneration has taken place, तो उसका फायदा नहीं होगा, because then you can't revert back. You are going to be helping future. So your newborn screening becomes important. And only one thing in 10 seconds I want to flag, there is because there are obstetricians there and fetal medicine expert, there was a report in New England Journal of Medicine last year, in which a pregnant mom was given at 35 weeks risdiplam, a pregnant mom, and then went on till the delivery time, and then the child was started after 8 days of life, the risdiplam, and later given the gene therapy. So they showed, the Roche had given them on compassionate grounds. They showed that the SMN copy numbers in the cord blood was higher than it would have been in the natural history case without the risdiplam. So maybe your fetal medicine and all, they may be maybe including these, and you may explore the other options. I don't know whether gene therapy can be thought of in the fetal medicine for you. So that was just a food for thought for you all to think. Thank you.
So the risdiplam has already been given in utero.
In
Yes, ma'am.
utero,
And
yeah,
that's
to mothers.
published in
Yeah. To the
New England
mother,
Journal
to the
of
mother.
Medicine. To
Yeah.
the mother, yeah, at 35 weeks
So
of
making our
gestation.
life more difficult,
Yeah.
whether to go for MTP or go for the treatment.
Yes, I mean that was there, and but there was only one report. I recently got another mom who they decided not to abort, and then they came to us from one particular religious thing. They didn't want the abortion, right? So
Okay.
so we tried to find out what are the approvals there to give the mom, but I just could not get any. So we have not given actually. So yeah, once you guys are interested, and then we can find out. We can ask the DCGI for approval and all for the pregnant mother situation. So that's a very
We just read that paper, so got
yeah.
excited because
Yeah.
anything, in utero works best for us. So,
February
No,
last year. Yeah,
but there's just one report. There have been some trials in animals, and even in animals, these animal trials, it was found to be teratogenic as well. And
this was given after, I think, 28 weeks in this
yeah,
case.
but
This is
Yeah.
tried
35
it in
weeks.
With the
animals,
first,
and there is teratogenesis reported. Maybe we can cross that organogenesis period and then give, and it will still benefit the baby.
yeah. So anyway,
Maybe,
CVS will give us late diagnosis only after organogenesis.
yeah.
Right? So probably, I think, so now we request few words from you also, Dr. Sangeeta. So your perspective on this SMA, because everybody is of a different, we are multidisciplinary today. So different perspective. You are
So muted.
Yeah.
So from my perspective, first of all, good evening, and I have to thank Dr. Seema for including me. I'm really happy because this is one moment which stimulates us all to read extra for a particular topic. As far as an obstetrician and fetal medicine person is concerned, my role is very little. It is the geneticist who has the major challenges. But what I have observed in the practice and what data also supports is that whatever the international incidence may say, but in India, after thalassemia, this is the most common single gene disorder. And consanguinity being very prevalent in this part of the country, especially in Loknayak, where we get a lot of patients with consanguinity, it is very important that that we should at least make them aware, make a good pedigree chart of these families, unless we can come to that level of care where we can offer universal screening to all these cases. So that is one thing I want to say. And in India, there is a serious, as Dr. Seema has already said, that it has been recommended by SIAMG for universal screening of SMA in India. Am I right, Dr. Seema?
Yes, universal
So I
screening.
think
Along with thalassemia, two disorders, thalassemia and SMA.
so it is very relevant in our setting, and that's a good proposal. Now, how we bring it, how we really implement it universally is the next challenge. And as an obstetrician, I don't have much role except that to make a prenatal diagnosis.
You
Uh,
can raise the awareness
yes,
because when we write the carrier testing, the acceptance is poor because again the cost is for
cost
them.
is yes, the cost is a challenge for our patients.
Yeah. So, Dr. Upma, we request few words from
Yes.
you. Yeah.
So good evening, everyone. At the outset, I want to thank MedGenome and Dr. Seema for inviting me for such a stimulating panel on SMA. And SMA, as just we discussed, it is quite common in India. In a study, it is found that the carrier rate is as high as 1 in 38 compared to the rest of the world, where it is 1 is to 40 or 50, and the incidence is around 1 in 10,000. And I have seen many cases where the first baby was diagnosed as having SMA, and the mother has come this time because it's very traumatic for the mother seeing their baby not able to walk, not able to feed, having respiratory infection, and then dying. So that mother we were able to help, and we did a CVS because she had come in first trimester only, and the baby was a carrier. So whenever we have a history or a proband, we can offer something to this patient. And as the incidence is carrier status is so high, I think we should go to a point where we should be able to offer carrier screening or newborn screening. And now with disease modifying therapy also on the horizon, I think early diagnosis the treatment, if they carry on the pregnancy, can be started immediately after birth, giving a better outcome for these patients. So definitely, and with the SMN1 and SMN2 genes there, look where we have to look. So at the beginning I was confused, what is the carrier state, what is the affected. So when it is heterozygous, it is carrier, and if it's homozygous at exon 7 and 8, it is the baby is affected. So the CVS we did, we got exon 7, 8 heterozygous, and we got confused, and we realized that when it's homozygous, it is a affected child. So that mother was very happy. It was just a carrier. We just counseled that the baby, when she gets married, then they should look for, then we have to increase the awareness. We know it is autosomal recessive disorder, and if the future partner is also affected or the carrier, then there's almost 25% chance, like thalassemia, that the baby will be affected by SMA, which is we know it has a spectrum, and it's a bad disease. So I think it's a time when we should become ourselves more aware, because if we become aware, then only we can talk about this and make other people also aware. So many now parents are coming like thalassemia with a prior diagnosis, whom we are helping. So it's a good way.
Thank you, Dr. Upma.
Thank you.
I think Dr. Jaya, have you been able to join?
Yeah, she's there.
Yes, ma'am.
Yeah.
Good evening, ma'am, and good evening, everyone.
Good evening. So I request you, your perspective for this webinar today.
I'm on an interesting path, ma'am, where I come from a government setup, but our patients have deep pockets. So I am somewhere in the middle ground between public and private sector insofar as fetal medicine is concerned. And I would say we are learners along the curve, and I am the youngest of all among them. So what I would say is that I would be interested in knowing more about what are the finer nuances for genetic testing. So of course, we know this is autosomal recessive, and we have a standard battery of tests to offer. But I have read about this, that they are sometimes missed by the general tests that we offer, and therefore we have to go deeper into the network of genetic testing. So I'm here to learn about that, number one. Number two, I'm intrigued by the fact that we have a universal carrier screening program that can be offered potentially for SMA. And I'm curious to know about the medico-legal aspect of how will it turn out if we do not offer it to our patients. And someday some baby turns out to be an SMA positive. What will be the implications for the clinician in that regard? Should we start offering it, like, for example,
with the guideline in place, probably, it can impact us, I think.
Yes, because like we said, the American College of Medical Genetics at one point said that NIPS should be offered to all, regardless of, like, we should tell them that there's a test like that, whether they opt for it is not or not is completely their ballgame altogether. So I'm not sure whether we stand on a similar footing for SMA. But yes, I would like to understand more about the finer nuances of how it impacts us on a regular basis in our clinical practice. And the third and the final thing
we start implementing in the clinical practice, the more the awareness will increase and the people will accept. So that's what the idea is, to involve all obstetrician, fetal medicine specialists in this webinar, so that the awareness is generated, and it can help many, those, because you touch lots of lives compared to us. So that is the idea, that we empower you with the knowledge which we have learned over the years in the the diagnosis and the carrier screening, the prenatal. So probably we can impact. So
yes.
Dr. Sunita,
I just
have you been able
add,
to join, Dr. Sunita?
I just want to add, Dr. Sheeba, earlier the patient used to come with the muscle biopsy or some neurological, but now they're coming with a molecular testing for the child who has already expired. So that's also great. Otherwise, we were not able to, what to do in CVS if we don't have the genetic testing of the proband. So now with the test being available, affordable, the patients are coming with that. CVS we did, she had come with the molecular diagnosis of the
previous child.
Previous child had already expired.
Yeah. That's a big improvement of the genetic testing. We have reached a different level. Genetic testing has actually reached the doorstep. So, it is the provider has to, now take up that they need to be aware that when to prescribe and how to, interpret all these. So thank you, everyone.
I'll just get to ask here, ma'am, that, like, should carrier screening be a part of our preconceptional counseling in today's times as a standard practice?
Yeah. So the ideal time is preconception or early pregnancy. Yeah.
Yes.
And the other thing is pro-fetus. We are no longer asking them to do a CVS and terminate their pregnancies because the world is going towards a conservative policy. We would like our children to thrive with the medications available. And let us not assume that our parents are too poor.
Yeah, no. We should not be their financial. Everybody has talks, like, So now it's time to begin our academic session. And the first is the SMA diagnosis and treatment. And Dr. Sheeba Farooqui, who is the assistant professor at Department of Medical Genetics, PGICH, Noida. So Dr. Sheeba, yeah. So Dr. Sandhya, would you like to, her CV? Okay. So she is an assistant professor and she is MBBS DNB DM Medical Genetics at Kasturba Medical College, Manipal. And she is a formal consultant clinical geneticist at MedGenome. And she has lots of publication in peer-reviewed national and international journals. And her area of expertise is neuromuscular disorders, clinical dysmorphology, genomic variants, interpretation, and prenatal genetics. So I welcome Dr. Sheeba. You can share your screen. Dr. Sheeba, are you there?
Yes, ma'am. Good evening, ma'am. Am I audible?
Yeah, you're audible.
So start sharing your screen.
Ma'am, is my screen visible?
Yeah, we can see your screen.
Make it full screen, Sheeba.
Now is it full screen?
No, it's not.
Not yet. So,
ma'am, it is showing. I'll unshare and then I'll share again.
Maybe you can go to the top panel and choose slideshow from there. It might just work.
Okay. Is it showing full screen now?
No, not at all. Now that also has gone. The previous one.
You open it, then minimize it, and then share it. Open, minimize, then go to share.
And then you open from the below.
Yeah, Abba.
Now, okay. Yes.
Yeah, it's full screen now.
Yeah.
Okay.
It's slides.
Okay.
That's okay. Yeah.
A very good evening to all of you present here. First of all, I want to thank Dr. Seema Thakur ma'am and MedGenome for inviting me to this webinar to speak upon the topic spinal muscular atrophy, diagnosis and treatment. So as we all know, spinal muscular atrophy or SMA, it refers to a group of hereditary disorders which primarily affects the motor neurons. And it is characterized by muscle weakness and atrophy, leading to a gradual and a progressive degeneration and an irreversible loss of the anterior horse cells, which are located in the spinal cord, as well as the brainstem motor nuclei. So as we all know, SMA is an autosomal recessive disorder. So basically, we will be discussing about the proximal SMA or the 5q SMA in this discussion, which is the most common form of SMA, and it accounts for about 95% of the SMA cases. It is caused by a homozygous deletion or variations in the survival motor neuron 1 or the SMN1 gene. The incidence of SMA, it ranges from 1 in 7,000 to 1 in 10,000 live births in India. And the carrier frequency ranges from 1 in 30 to 1 in 38 in the North Indian population. And SMA is also a leading genetic cause of deaths in infants globally. So moving on to the pathogenesis and cause of SMA. So all human beings have nearly two identical SMN genes. So SMN1, which is the telomeric copy of the SMN gene, and SMN2, which is the centromeric copy. It depends upon the location. SMN1 is located more towards the telomere, whereas SMN2 is located towards the centromere. And both these SMN copies, they have more than 99% similarity, and they only differ in 8 nucleotides, and out of that, 5 nucleotides lie in the intronic regions, whereas only 3 lie in the exonic regions. So the SMN1, it produces the full-length functional survival motor neuron protein, and SMN2, which is the centromeric copy, what happens is that there is, because of the splicing, the exon 7 is not included in the mRNA, SMN2 mRNA. Because of that, the 90% of the SMN2, the protein which is formed from SMN2 translation is non-functional and it undergoes degradation. While because of alternate splicing events, only 10% of the SMN that is produced from SMN2 includes exon 7, and therefore it is able to produce only some amount of full length of SMN protein. Therefore, in individuals with SMA who have variants or homozygous deletions in the SMN1, the SMN2 is not able to compensate for the function of the lower motor neurons. So, moving on to variability of the clinical features and severity of SMA, as probably we are knowing that SMA has been classified into 5 types, ranging from type 0 to type 4. So the spectrum of severity of SMA ranges from mild proximal limb weakness, which is noticed in adulthood, that is seen in SMA type 4, to generalized weakness with respiratory failure in the neonatal period, which is observed in SMA type 0. The predominant clinical features observed in SMA include muscle weakness, atrophy, hypotonia, areflexia, hyperreflexia, fasciculations, hand tremors. The weakness observed in SMA is usually symmetric and predominantly proximal. The lower limbs are usually more involved as compared to the upper limbs, and bulbar and respiratory involvement are usually associated with more severe limb weakness. So this is a pictorial representation of the clinical features and the severity which is observed in SMA. So SMA type 0, which is the most severe form of SMA, has a prenatal onset, and the individuals with type 0 usually have a short life expectancy. Type 1 onset is usually by 6 months of age. The infants with SMA type 1 are never able to sit without support, and in life expectancy is usually less than 2 years. In type 2, onset is usually less than 18 months of age. With the children are initially able to sit, but there is progressive decline in the motor functions, and they have a shorter life expectancy. Type 3 onset is usually after 18 months of age. They are able to walk, but there is further progressive decline, but it is normally associated with normal life expectancy. And type 4 SMA is adolescent to adult onset with normal life expectancy in most of the cases. So the severity of SMN, as we can see from this picture, it directly correlates with the number of SMN2 gene copies. So in SMA type 0, usually one SMN2 gene copies are encountered. And as we move towards SMA type 4, usually 4 to 8 SMN2 gene copies can be observed. So the onset and severity of the disease, as we have discussed, it correlates mainly with the SMN2 copy number. And also it has been found that even if there are variants in the SMN2 gene, which can increase the full-length SMN protein. For example, there is a well-known variant C.859G2C in exon 7 of SMN2. It can increase the exon 7 inclusion and number of full-length transcripts in approximately 20%. And also it has been found that higher expression of plastin 3. So this PLS3 gene, it is located on the X chromosome. It has been found that especially in the females who are harbor homozygous deletions or homozygous variants in the SMN1, there has been found a decreased severity in the phenotype, wherein there is higher level of plastin 3 expression. So the key testing methods in SMA includes the multiplex ligation-dependent probe amplification, because more than approximately 95% of the individuals, they have homozygous absence of SMN1 exon 7. So MLPA, it is the gold standard test for SMA, which not only identifies the SMN1 deletions, but it also helps in quantification of the SMN2 copy numbers. And SMN2 gene sequencing, wherein in cases we have a strong clinical suspicion of SMA, but we have found just one heterozygous deletion on MLPA, just for the confirmation of compound heterozygosity with another point mutation, to search for another mutation, SMN1 gene sequencing can be done. I will not be going into the details of testing testing modalities for SMA. It will be dealt in detail in the next session. So moving on to the therapies that have developed for SMA in the last decade. So the approval of 3 disease-modifying therapies for SMA, namely nusinersen, which is an antisense oligonucleotide, onasemnogene, which is a gene replacement therapy, and risdiplam, which is an oral splicing modifier. So they have drastically transformed SMA from a fatal condition into a treatable disease. The therapies in SMA have a positive impact on the natural history of the disease if they are initiated prior to the onset of manifestations of the condition. And after confirmatory SMN1 genetic testing, targeted treatment is usually recommended for all the individuals who have 2 to 3 or 4 copies of SMN2, irrespective of their disease manifestations. And for individuals who have one copy of SMN2, targeted treatment is left to the discretion of the treating provider on whether depending upon the severity of the condition. And individuals who have 5 copies of SMA, targeted treatment may be deferred until the onset of symptoms, but these individuals have to be followed carefully, and the involvement of a neuromuscular specialist is recommended. So moving on to the first therapy that has been approved for the treatment of SMA recently, it is nusinersen, which is an antisense oligonucleotide that modifies the SMN2 pre-messenger RNAs, splicing of SMN pre-messenger mRNA, and it causes the incorporation of exon 7. So as we can see in this picture, this is the SMN2 gene. This nusinersen, or the brand name Spinraza, it binds to the splice silencer site located in the intron 7 of the SMN2 genes. As a result of that, it modifies splicing event, and it leads to the incorporation of exon 7 in the final mRNA, and eventually it leads to the production of a highly stable and fully functional SMN protein. So this drug was approved by the US FDA in December 2016 and by the European Medicines Agency in June 2017 for individuals affected with SMA belonging to all the age groups. Nusinersen is administered intrathecally. There is a uniform dosage of 12 mg for all the SMA patients, which is given every 4 months after the loading period. So the loading period, 4 doses are given in the loading period. The dose is 12 mg. In the first 3 doses are given 14 days apart, and the 4th dose is given 30 days after the administration of the 3rd dose. And after that, every 4 monthly, 12 mg maintenance dose is given, and it requires lifelong therapy. So there have been several pivotal clinical trials to assess the efficacy, safety profile of nusinersen. So NDA trial, it was a phase 3 randomized double-blinded trial. It was a sham-controlled trial wherein 122 symptomatic infants who were less than 7 months of age were recruited for this study. And in this study, the study was conducted for a period of 13 months. And in this study, it was found that 37 of the infants, that is approximately 51% of the infants, they showed improvement in the motor milestones measured using the Hein or the Hammersmith Infant Neurological Examination Scale as compared to the sham control group, wherein the motor improvement was not observed in any of the individuals. And then also it was observed that 61% of the individuals, they survived without any permanent ventilation as compared to the sham control group after the period of 13 months. There was another pivotal clinical trial, which was known as the Cherish trial. It was a randomized double-blind sham controlled trial, which was done to assess the safety and efficacy of nusinersen in children and basically in later onset SMA, like SMA type 2 and type 3. In this study, 126 children, they were recruited. They belonged to the age group of 2 to 12 years with symptom onsets after the age of 6 months. So this study was conducted for a period of 15 months, and it was found that there was increase in 3.9 points in their Hammersmith Functional Motor Scale Expanded score at the end of 15 months. And as compared to the control group, wherein there was only 1 point increase in this HFMSE, which was seen in the control group. So this difference was statistically significant. There was another open label nurture trial, which was done to assess the efficacy of nusinersen in the pre-symptomatic infants. So this was continued for a period of 5 years, and 25 pre-symptomatic infants with confirmed molecular diagnosis of 5q SMA, they were recruited for this study. 15 participants, they had 2 copies of SMN2, whereas 10 had 3 copies of SMN2 in this study. And at the end of 5 years, all the 25 participants, they achieved independent sitting. 14 out of 15 children with 2 SMN2 copies, they could walk with assistance. And out of these 14, 6 attained this milestone within the normal time frame. 13 out of these 15 children could walk alone, and 6 walked within the normal time frame. And all the participants in the study who had 3 SMN2 copies, they achieved all their WHO motor milestones, and 9 out of these individuals, they achieved all their motor milestones within the normal time frame. So from the conclusion that was derived from the study was that treatment benefit is maximum when the therapy is initiated early, and motor milestone achievement is greater in individuals who have higher copies. That was 3 number of copies in this study. So moving on to the safety profile of nusinersen. So a 5-year open label follow-up study for the patients was conducted who had previously participated in the nusinersen trials like the NDA trial and the CHERISH trial, which we have discussed previously. So nusinersen has demonstrated a favorable safety profile in all the clinical trials, and no treatment-related serious adverse effects were reported in the SHINE study. The adverse events were generally manageable, and those included mainly pyrexia that was observed in 65% of the participants, upper respiratory tract infections in 54%, and post-lumbar puncture symptoms like headache, vomiting, or local site pain, it was observed in 46% of the participants. And there were noticeably 0 study discontinuations due to drug-related side effects. Now, moving on to the second approved therapy for SMA. So this is onasemnogene, which is a gene replacement therapy for SMA. It was approved by FDA in May 2019 as IV gene therapy for SMA patients who were less than 2 years of age. And very recently, in November 2025, it was approved as an intrathecal formulation for older patients between 2 to 18 years of age who had biallelic mutations in the SMN1 gene and had 3 or lesser copies of SMN2, or those who had infantile onset SMA. So it is basically an adenovirus associated viral subtype 9 based gene delivery system. So this virus is used to deliver a fully functional copy of the SMN1 gene directly into the motor neuron nuclei, as we can see in this picture. And this construct SMN gene does not incorporate into the genome, whereas it functions as an episome. So it prevents the insertional mutagenesis, and it remains there, and it generates the the functional SMN protein. So this therapy, it is administered as a one-time infusion. So a number of pivotal clinical trials have also been done to assess the efficacy as well as safety profile of onasemnogene. So a phase 3 open label study was done in US as well as in Europe. That was known as the STRIVE study. So in STRIVE US, 22 participants were recruited. And all these individuals, they had onset of SMA, they had type 1 SMA with onset at less than 6 months of age and had 1 to 2 copies of the SMN2 gene. And the single dose one-time IV infusion of onasemnogene was given to them before 6 months of age. So what was found in the STRIVE US study, out of 22 participants, 91% were alive without requiring any permanent ventilation at the end of 14 months. And 13 patients achieved independent sitting by the age of 18 months. And in the STRIVE study, which was conducted in Europe, it showed that out of 32 participants, 31, that is approximately 97%, were alive without permanent ventilation at 14 months. And 14 patients received independent sitting by 18 months of age. Another trial known as the SPRINT trial, which was an open label single arm clinical trial, which was conducted for assessing the efficacy of onasemnogene in 29 pre-symptomatic infants who were treated within 6 weeks of life. So it was found after 18 to 24 months of follow-up, it was found that all the individuals, they have survived without permanent ventilation at 14 months. And here also in the study, out of total 29 participants that were recruited, 14 individuals had 2 copies of SMN2 gene, while 15 had 3 copies of SMN2 gene. So it was found that individuals, that greater benefit was observed in the motor domain in those who had 3 SMN2 copies. 93% out of the individuals who had 3 SMN2 copies achieved independent walking by the end of 18 months, compared to 64% only who had 2 SMN2 copies. Moving on to the safety profile of onasemnogene. So the safety concerns are of onasemnogene gene therapy is highlighted in both the clinical trials as well as in the real-world data. And the primary concern is hepatotoxicity or acute liver failure, which usually manifests within days and weeks of administration. So for the same, patients require intensive prophylactic regimens of oral corticosteroids, starting from 1 day prior to the administration of this gene therapy, and it is tapered over several months. Other adverse effect that was observed in various clinical trials and also from the real world data was thrombocytopenia, which is rapid and transient, and it usually occurs within the first month after the administration of this gene therapy. Also, rarely observed in these individuals is thrombotic microangiopathy, which typically is seen within first 2 weeks of the administration of onasemnogene therapy. But in the long-term surveillance data from various clinical trials, it was observed that no unexpected or late-onset safety concerns were found. Moving on to another therapy for SMA, which is a wonderful orally administered therapy for SMA, which was approved by US FDA in 2020 for patients older than 2 months, and it was approved in the year 2022 for individuals with SMA belonging to all the age groups. So it is an orally administered therapy for SMA, which is given once daily. It is a small molecule which modifies the SMN2 splicing. So as we can see in this picture also, this small molecule, risdiplam, it binds to the 5' splice site of intron 7, as well as it binds to the splicing enhancers located on the exon 7 of the SMN2 pre-mRNA, and then it modulates the splicing event, and it leads to the incorporation of exon 7 in the SMN2 mRNA, and it eventually leads to the production of functional full-length SMN protein, and it leads to the production of full-length SMN protein, maintaining the function of lower motor neurons. So several pivotal clinical trials were also done for risdiplam. So for individuals, there was a Firefish trials which was conducted for infantile onset SMA, that is SMA type 1. And in this trial, 62 symptomatic infants who belong to the age group of 1 to 2 months with onset before the age of 6 months. So it was done, and it was found that independent sitting was observed. Independent sitting was attained in 29% of the infants for more than 5 seconds in 12 months. And with the long-term follow-up that was done for a period of 5 years, it was found that independent sitting was attained in 59% of the participants for more than 30 seconds. 91% were alive, 81% were free from permanent mechanical ventilation, and 96% maintained safe swallowing function, and 80% did not require any gastrostomy tube for feeding. Another pivotal clinical trial was done for later onset SMA, that is type 2 and 3, which was the Sunfish trial. And this trial included 231 participants belonging to the age group of 2 to 25 years. So the results were analyzed at the end of 12 months, and then a long-term follow-up data at 5 years was seen. And at the end of 12 months, it was found that there was significant positive change in the motor functions in the control group as compared to the placebo group. And even in the long-term data, it was found that younger children who got the therapy, like the individuals belonging to age groups 2 to 11, they have experienced more active gains and major improvements in their motor functions as compared to the older adolescents and adults, which have primarily experienced disease stabilization. Moving on to the safety profile of risdiplam. So the long-term data and the real-world experience, they have greatly shown that risdiplam is a well-tolerated therapy, and it provides a sustained benefit across all the age groups, individual belonging to all the age groups with SMA. And the common adverse events that have been observed with this drug are pyrexia, diarrhea, rash, and upper respiratory tract infections. And the advantage of risdiplam, which it offers over other SMA therapies, is that it is orally administered. So as a result of that, the procedural associated risks like headache, vomiting, and the localized pain, they can be avoided using risdiplam therapy. So apart from the therapies which have lately been developed in the past decade for SMA, multidisciplinary care is essential in the management of SMA. Proactive multidisciplinary management by a coordinated team is essential because it is important to improve the outcomes in individuals with SMA and also to prevent complications in the individuals across their entire lifespan. The multidisciplinary evaluation is important to assess the nutritional state, the respiratory functions in these patients, the motor functions, the orthopedic status, and also to determine the appropriate interventions which may be required during the course of their lifetime. So, to conclude, spinal muscular atrophy has transitioned from a uniformly progressive and often fatal disorder to a treatable disorder with the advent of the recent therapies, the molecular diagnosis, and even newborn screening nowadays. Early identification through newborn screening and prompt initiation of treatment remains the most important determinant of the outcome in individuals with SMA, and emerging therapies. They further aim to optimize the outcomes and reduce the disease burden in individuals with SMA. Thank you. These are the references.
Thank you, Dr. Sheeba, for such an extensive talk on the diagnosis and treatment. You have given us a good, understanding, good insights on these. So now I request Dr. Shefali, her experiences with all these treatments, like 3 major treatments, like the nusinersen, the gene therapy, the risdiplam. And also I would request your opinion on this NATCO NatSmart, the Indian version of this risdiplam. So, Dr. Shefali, are you around?
Yes, I am around. Don't ask me the last statement. Next time I'll tell
Okay.
you.
Okay.
And
So,
I'll
just
just
your
tell you which is
experience, how
yeah,
you.
yeah. Anyway, I was saying jokingly that if something was, I logged from the laptop and mobile. There was some problem with the LAN. So, also what happened? The experience we had, the first gene therapy in India for SMA, we did on 29th of May 2020. Peak COVID shuru ho gaya tha. But that time, because 2020, the Novartis started a free program, which was called GMAP program, a global access program. Every 2 weeks, they used to select 2 patients globally free of cost. So our patients were selected, and there was both the parents were doctors. So I had to take special permission to do that during COVID times because all elective procedures were cancelled that time, right? So that was the first patient we did. We have done 26 patients thus far. So in this journey, what we have seen is all patients improve. All patients improve, but one thing is there is definite hepatotoxicity. We start steroid 1 day prior to giving the gene therapy, and you may need to give steroids minimum 30 days, but I have given up to maximum of 6 months because you have to monitor the SGOT, SGPT, the tropi and platelets. And because the reaction to by the host is to the AV9 vector. So this reaction is not to the gene, it's to the vector. So vector ke response ke liye it is there, and we have to keep monitoring regularly, and we monitor, and then you have to continue giving steroids so long. So I told you I have given up to 6 months also. So that is one thing. So we are not worried about that. For thrombocytopenia, around 18% of my patients had thrombocytopenia, but only one needed the platelets. Baki sab theek ho gaya. Tropi was raised in couple of them, but nobody had any abnormal cardiac function, was okay. So it has been safe from the safety point of view because that's the most toxic than the others. But all of them improved the motor milestones. But most of my patients which were there were, I had one or two, 9, 10 months, but others were all 12, 13, because they were being diagnosed late. And SMA type
Type
1
2 mainly. You had type 2
yeah,
cases mainly?
टाइप 2 भी है पर 1 भी है पर मतलब जो
Okay.
1 है वो भी थोड़ा सा लेट हो गया ना बिकॉज बाय द
Ah.
टाइम बिकॉज व्हाट वो अब 1.5 years से तो वो हो नहीं रहा दैट लॉटरी थिंग इज गॉन सो नाउ दे हैव स्टॉप and even pehle I used to fill 200 forms. We used to get only 2 lotteries in the globally, so the others were waiting, they were not having, so the delay got because of the access, right? Second is I have experience in 47 patients receiving nusinersen that is there from Biogen. We got it free of cost, pro committed for life by Global Direct Relief for 230 patients in across India. In 2019, I started giving them in December 2019. Second Alicot from 2020 March, and they had given 30 and 200 patients in the 2 Alicots for entire country, out of which 47 are our patients. So they have been giving free of cost. Each injection is $75,000, and first 4 injections are there in the loading, and then 4 monthly lifelong. So usme bhi there is a lot of improvement, but I'll tell you, problem is there are no side effects coming, hardly any side effects. Problem which is coming is the ones who have become bigger, because I have some who have grown into adults also now because they were adolescents. So there, scoliosis sometimes if your cob angle is very much there increased, so that may be a technical problem to put it. So in now 2, 3 patients, I have taken help from anesthetists to put. Third is risdiplam. Risdiplam being an oral medication is easier to give, and we were giving through Roche. Roche was giving through a Blue Tree program. May एक bottle खरीदो, 2 bottles free, something like that. So it was coming to around 72.4 lakh per year for a 10 kg child after that Blue Tree program, you know. But this Natco, which is a generic preparation, which one bottle is 15,900. But you know, they don't have bioequivalent studies. They have been given production rights by DCGI. But right now, why I said I won't make the statement, right now we are waiting for ministry's instructions on that, because even being the Central Technical Committee Rare Disease member, I raised this question. So they have Ministry of Health is having meeting with DCGI for the final stake of instructions for us to give to the rare disease thing. But yes, right now parents have started using on purchase because you know it's life saving that way, you know. But point is we have not started procuring through the National Rare Disease Policy. We are waiting for the for the directions from the ministry, and otherwise because it is available, so parents are starting. So there's a moment they come to know about the diagnosis, they are starting it because it's also available on India Mart and all. Also, it should not be available. It should be. I told them that it should not be available. I told the company it's not right. I was sent a
But it's
screenshot
available,
that
yes.
it's
Even I
available.
Yes,
came
So
to
available.
I
know.
told. I
Okay, so
told them.
probably we can have those cohort to have the data. So at to
No, but
because
yeah,
it's
no, no,
the
they are also
cost is
sure.
really it's remarkably
नहीं
different.
बट या इट्स रिमार्केबल डिफरेंट. जो मेरा रिस्डिप्लाम का डेटा बस एक लाइन है, उसके भी सिमिलर इंप्रूवमेंट्स है. रिस्डिप्लाम का डेटा का भी सिमिलर. तो मेरा जो रियल वर्ल्ड सिनेरियो इन इंडिया फॉर ऑल थ्री condition or three drugs in the intravenous Zolgensma, the intrathecal
Gene therapy.
nusinersen and the risdiplam, all are showing similar improvements because all of them have been there, you know, after 6 months they have been given, but there have been no magical improvements, but all have gained. But you need to give them a multidisciplinary care, give them the
Yeah.
ortho, you know, everything, orthopedic, nutrition, you know, endocrine and physiotherapy and respiratory stuff. All that has to be given, and they are improving. But the only thing is that whether risdiplam can be started in the moms, which is one thing to be kept. And second, my one request is to you guys, if you can, you know, because you can pursue population based screening, है ना. तो can you not have a carrier screening? और population based तो जब होगा होगा. US में है.
Yes.
Europe had committed to do population screening across all countries by 2030. So you know that is there. So India में नहीं हो रहा है. But can the obstetricians encourage? I mean, maybe you get only when they are pregnant. I don't know. I don't know how to
No,
do
no,
it.
there is already a guideline by Society of Indian Academy of
आपको
Medical
देखें.
Science. Yeah. So universal screening, this disorder has been included along with the thalassemia. So
पर
today's
आपके पास
Thalassemia.
webinar
pregnant आ
is
रहे हैं, पर आपके पास प्रेग्नेंट आ रहे हैं ना, तो फिर कैसे करोगे ना. I
early
mean,
pregnancy भी आते हैं और कोई बात नहीं लेट भी आता है तो we encourage them कि since there is a treatment probably
नहीं
it can help.
नहीं प्रेग्नेंट हो गई तो क्या फायदा कैरियर स्क्रीनिंग से.
We
I
can do
meant कि
CVS. Yeah, we can do
CVS
CVS.
prenatal diagnosis we
Yeah,
can do, na?
yeah.
okay that way, but I thought if they don't
And
marry
also
only.
somebody might get the Natco or the risdiplam. We don't know.
Yeah,
So
that's true.
yeah. So we have to avail all the explore all the options. So thank you so much, Dr. Shefali. You have given us so much of understanding of in such a simply, and what a memory that how many patients you have included, and how many. So it's wonderful. So now we move on to the next session. Dr. Sandhya, are you around?
Dr. Seema?
Yeah.
Yeah, could we, you know, we have such experts on the panel. I had a few queries. Should I bring them at the end or
You can ask with because Dr. Shefali can answer. Yeah.
okay? So for Dr. Shefali, I'm really impressed with your data.
Yeah.
It was an eye opener for me that so many children in India are also have been getting the treatment. Really, I was not aware of
More
this.
than 100,
We
I think.
always used to feel that our country can't just afford this. So this is a remarkable work. I must congratulate you first.
Yeah.
I just had one query, Dr. Shefali. Is there any dose modification with as the weight of these children increases?
Ma'am, no, Zolgensma may the intravenous Zolgensma comes according to the weight. The intravenous, the
Okay.
intrathecal one is there is a standard volume. For
Okay.
the risdiplam, there is a weight base, so they are weight bands. Same
Okay.
thing for Zolgensma. So and nusinersen also there is depending on the thing. So they are depending on that. Only but for nusinersen, there are standard. The initial high dose is there for the bolus, and then it is there. One thing I wanted to say, अभी वो nusinersen का एक नया आ रहा है salanersen. उसका एक प्री सिम्टोमेटिक एसएमए में ट्रायल स्टार्टिंग है, उसमें एनुअल हो जाएगा। मींस अभी तो 4 मंथली देना है उनको
Yes.
इंजेक्शन इंट्राथिकल, वो एनुअल देख रहे हैं। सो अगर वो
Yeah, this
More
is
convenient.
yeah,
Yeah.
for
that
is actually a concern. Giving it intrathecal is really a challenge, I think.
for
Yeah.
monthly, और बड़े वालों में I told you ना, 2 patients we have to take help from anesthetist to do it.
Yeah, yeah.
Because of the
Otherwise
scoliosis.
स्कोलियोसिस वर्सन हो गया है। एंड बट ये बोल रही हूँ कि 1 ईयर का हो जाएगा, एनुअल हो जाएगा तो थोड़ा सा इट मे बी बेटर
Yeah.
इन दैट सिचुएशन। या
And Dr. Sheeba, also, I must congratulate you on that lucid and crisp presentation. I just wanted to know, you had talked about some SMN2 variants and plasmin, which modify
ma'am.
the
Yeah.
clinical, which modify the phenotype of the disease. So are these two also amenable to genetic testing? Can we do a genetic testing and tell what is the status of a particular person with respect to these two variables?
I think Dr. Sandhya will answer all these.
Okay.
Maybe she will be able to answer. So I think with Dr. Sunita, have you been able to join?
She was there,
Yes,
Dr.
yes,
Seema.
I'm here.
Yeah. If
Good
you
evening,
can
everyone.
add to your experience also.
Well, enough has already been said, so I don't think I need
Everybody
to
has a
add anything.
different, so like if you can add to the existing on Dr. Shefali's, you have different issues.
Our experience is similar to Dr. Shifali's, but of course, her number of patients and the expertise is much more. So we are a genetic center, and we also do look after patients with SMA, and we have been treating right from 2020, as Dr. Shifali had said. We did start outpatient with risdiplam, and over the years, all the 3 types of treatments have been given, and we feel that slowly and steadily our patients are showing some progress. So this is regarding treatment, and of course, it's not just the one drug that acts. We have to have a whole team of physiotherapists and nutrition, and every other aspect needs to be taken care of in order to for the wholesome and we also hold 3 monthly clinics, multidisciplinary clinics for our patients with SMA, with the help of Cure SMA, that is the parent foundation. And this has been a
They're
great
doing wonderful job. Yeah.
So this is all regarding management, and of course we also do propose lot of carrier testing. As Dr. Seema already knows, we like Dr. Professor Verma was our father figure, and he in fact brought out this study with carrier frequency of SMA in our country. So
and the concept of 1 plus 0 and 2 plus 0.
Yeah, absolutely. He is the one big proponent
1 plus
of
1 and 2 plus 0. Yeah.
Yeah. So we've been doing carrier testing ever since, and it is allowed because the Society for Indian Academy of Medical Genetics has come up with their guidelines and recommendations for carrier testing with SMA in all couples in India. So we are a big proponent for that. And of course, we have been doing prenatal diagnosis for all of these children right from the very beginning. So we are
And you
all
do
in
lots of
there.
diagnosis also. So how your diagnosis timeline has changed after this molecular genetics?
Yeah. So basically, we were making this diagnosis from a very simple PCR test 25 to 30 years back. But with now, with the treatments that have come up, we are also wanting to know the genetic types of the SMA with the number of SMN2 copies. So we are now doing MLPA. Sure enough, there are many other methods, and I'm sure Dr. Sandhya will throw light on that.
How this has changed the diagnosis for me. Earlier, I was doing the couple carrier when I used to suspect SMA in the previous child, and now I find that the patient already had a diagnosis of the previous child who is no more. So now that type of shift is there with the molecular diagnosis in place.
Absolutely.
So that has actually simplified the diagnostic journey for SMA, because earlier it used to take a long to make the diagnosis. Sometimes many of the children would succumb also without having the diagnosis, and with lots of differential diagnosis we used to do the parental testing, and then so thank you.
And all age groups, like now even we get adults with, because of the awareness, all the adult neurologists, pediatric, even pediatricians, all fields, they are now starting to suspect, and we get patients from all over. So it's a heartening to see once the treatment and then awareness and carriers, and I
But
heard
many of the patients
even
are still
people.
not aware of these SMA, that there is a
Yes,
treatment available. So I think there is lots of work. So you do all aspects of care for SMA,
absolutely.
from diagnosis to carrier screening to prenatal diagnosis. So doing wonderful job to,
Yeah.
for these type of patients. So thank you, Dr. Sunita.
Thank you.
And
Thank you so much.
so now we move on to the next session, who will be equally insightful, and by Dr. Sandhya Nair, who is a, can I have her CV please, Ayushi? So her title is Genetics and Approach to the Molecular Diagnosis of the SMA, the most awaited talk to clarify the concept of 2 copies, 3 copies, which I keep on explaining and, is still unable to, explain. So probably, Dr. Sandhya, and so you will be discussing all these through your talk. So Dr. Sandhya Nair is a lead genome analyst at MedGenome, who is specializing in variant interpretation and NGS germline clinical reporting. She holds an MSc in microbiology and PhD in applied biology from the University of Mumbai. And she is experienced in analysis and clinical reporting of gene panels, carrier screening, trio analysis, and other NGS-based genetic tests following the ACMG guidelines. She has played a key role in initiating the MedGenome's carrier screening test and contributed to the research on the carrier frequency of the common genetic disorder. And everybody knows that she is a passionate, those who work with her, passionate about advancing the clinical genomics through accurate variant interpretation and evidence-based reporting. So welcome, Dr. Sandhya.
Thank you.
We are looking forward to your, so please share your screen.
Are you able to see it? Yeah. So I would be talking on genetic and molecular approach to spinal muscular atrophy. The points that I would be touching upon is history of SMA, the
Sandhya, it's
genes.
not slide full screen. Can you?
It's
We are
not
seeing two
1 minute, please.
slide share.
Yeah, 1 minute. I'll just stop sharing and then share again. Is it visible now?
It's not yet full screen.
Not full screen.
Full screens. Just click here. You can click below slide share. Then it will become full screen. Just click, go down. There's icons. You just
Right-hand
click
corner,
right-hand corner. You just
of your screen. Or from the top, the slideshow, Dr. Sandhya? Top one?
Can I just, wait, can I just stop sharing and then share again?
Okay. So till the time she is arranging, actually the history of SMA is also equally, interesting. This history, I just, while reading through this, I came to know that the history they divide for SMA into 3 parts. First is of 104 years old history, that is from 1891 to 1994, till the time the SMA gene was identified, the SMN gene was identified. In 1891, 2 cases of SMA, which were actually the type 2 cases of SMA, they were, diagnosed by, Dr. Wadnik, and in his honor, the type 1 is known as, actually his cases were type 2 SMA, but because to honor him, the SMA earlier was called the Wadnik-Hoffman disease. So 1891 to 1994, it was all about the diagnosis. You can start sharing, Dr. Sandhya. You're not able to share? You share, I'll stop in between. Yeah. So, and the second part is 1995 to 2016. Till the time the gene SMN gene was discovered, and till the time the FDA approved the
full screen now.
Yeah, this is full screen. And third phase is beyond 2016.
Yes.
You have already taken history. Okay.
Yes.
Okay. You revise
Okay. So after the history, maybe SMN gene structure, genetics.
You go through it. It will revise everyone. It is interesting, actually.
Yes. Molecular approach and the tests that we offer.
Yeah. Everybody has a different way to tell the history.
Yes. As you rightly said, so the earliest documentation is in 1891 by Wadnik. He described 2 infant brothers, followed by 7 additional cases by Johann Hoffmann between 1893 and 1900. So after that, as you rightly mentioned, Werdnig and Hoffmann's were eventually associated with severe infantile form. However, the cases were of intermediate severity. Then came the description of the severe infantile form that was made by Sylvester and Beaver in 1899 and 1903, followed by milder form of SMA in which the patient retained the ability to stand, walk with prolonged survival. It was not described until 1950s. It was documented by Wolford, Fez, and Allison. Later, in detail, it was described by Kuhlberg and Wielander. They describe the milder form of SMA.
Hello.
Yes, doctor.
No, that is
Yes.
somebody. Yeah, you go ahead. Go ahead, Dr.
Yeah. So during the next half century, the variability in the severity was further defined and characterized. The classification was then highlighted as 3 basic type of SMA based on highest level of motor function, sitting, standing, and the age of onset. In 1900, Wood et al. Documented the genetic mapping of chronic childhood onset spinal muscular atrophy to chromosome 5q11.2 to 13.3. 1991, then it was the formal classification that was published. And 1995, Judith Melke described the gene SMN1 and gene SMN2. From there on, it's the decade of transitional research, which started from 2000. There were a lot of preclinical trials and mice, clinical trials, and FDA approvals, as Dr. Sheeba mentioned. So, coming to SMA, it's a neurodegenerative disorder caused by mutation in SMN1 gene, the survival motor neuron protein. It is an autosomal recessive disorder, and it is located at 5q13. And it is extremely crucial for the survival of anterior horn cells. And the reduced expression of SMN leads to loss of alpha motor neurons and severe muscle weakness and often early death. The incidence, as it has already been mentioned, it is 1 in 4,000, 5,000 to 10,000 live birth. And SMN2 becomes very critical. It is an analogous gene which produces only 10% of the functional protein relative to SMN1. So, we've been speaking about SMN1 and SMN2. There are certain genes which are very important for the phenotype and especially spinal muscular atrophy. But the frequency of these particular genetic variants are much lesser. However, there are UBA1, DYNC1, H1, ASCC1, TRP4, VAP, BC, all these genes are also associated with spinal muscular atrophy. So now coming to the SMN gene structure. So if you can see, this is a gene which is approximately 20 kb in size. There are essentially 9 exons, which are historically labeled as 1, 2A, 2B, 3, 4, 5, 6, 7, and 8. As you can see here, you have a stop codon, which is in exon 7. So essentially, it means that your exon 8 is non-coding and is a part of the untranslated region, the 3' untranslated region. So basically, this protein is divided into the functional domain being gemin-2 binding, then there is a nucleic acid binding domain, then there is a chromatin binding domain, and there is a proline domain and the YG domain. So your 7 essentially is crucial for SMN oligomerization and protein stability. SMN1 and 2 are extremely identical. Just repeating the slide, but just the point that I wanted to make was what Dr. Sheeba mentioned, this T and this C. In SMN2, there is a skipping of this particular exon because there is an essential splice enhancer which skips this particular 7 exon. Hence, approximately 90% of the protein are degraded. Only 10% of the protein is functional. However, in SMN1, because this is a C, it continues and it produces a functional protein. About 90 to 98% of the variation can be attributed to the deletion duplication, and for the rest of 2 to 5%, we need to go for the gene sequencing. So as we can see here in the ClinVar database, we see that majority of the variants that we see are deletions and duplications. However, if you look at only the pathogenic and the likely pathogenic variant, it majority being the deletion and some frame shifts, nonsense, etc. So if we go for the diagnostic algorithm for spinal muscular atrophy, once you suspect an SMA, you can go in for deletion duplication, which is MLPA. Based on the number of copies, we can further evaluate. If there is no mutation, then the last would be your NGS. You have SMN2 evaluation also that is done with the help of MLPA, which helps in the therapies, as it was mentioned previously. So coming to MLPA, it is a basic technique to study the gene copy number variation. It can be used to study the genetic, the copy number variant either in a specific gene of interest or multiple genes. Coming to the schematic representation of MLPA probe. So here we have a left probe oligonucleotide. It comprises of this region, which is very specific to the gene of interest. And then you have a primer binding site. Similarly, the right probe oligonucleotide, this region is extremely specific for the gene of interest. Then you have a stuffer sequence, which will give you, which can change with respect to the size of the amplicon that you get, which is required for analysis, and the binding site of the reverse primer. Coming to the steps involved, so you have 6 basic steps. One is a denaturation, hybridization, ligation, amplification, fragment separation, and analysis. Denaturation, the purified DNA is denatured, and this single strand we hybridize with a mix of specific MLPA probes that are incubated overnight. So this mix contains specific MLPA probe, which is specific to the region of interest. Now, if you have this probe as well as this probe binding very specifically to the region of interest, then the ligase will come and sit here. So it does not allow any mismatches. If there is a mismatch, the ligation wouldn't happen. So the ligation reaction is extremely specific, and it will only ligate if there is a complete sequence. So now once this is ligated, the whole of the region becomes like a specific region for amplification. So now after this step, you have amplification. So the ligated probes are amplified in multiplex PCR. So only the ligated probe will amplify. If you have any probe which is not bound properly, which is not ligated, it will remove all the unbound and non-ligated probes. Now, I showed you the stuffer sequence that is required to get different sizes of your product. So depending upon the fragment size, it gets separated on a capillary gel electrophoresis, and an electropherogram can be drawn based on that. So this is then further kind of analyzed based on the reference data, and you get the ratio chart, which we will come in the next slide. We do have controls for it. We have control which checks the DNA amount. It checks how the ligation has happened. It also checks whether the sample that has been processed is XX or XY. So depending upon the probe, you are able to differentiate the gender as well. So now coming to interpretation, this is very critical. So assuming that you have 1, it means that it is normal. If it is 0.5, it is termed as heterozygous event. If the ratio is 0, it means that there is a homozygous deletion. If the ratio is 1.5, it means that there is a heterozygous duplication. And 2 means homozygous duplication. So basically, there is a chart which is generally referred to, which shows that depending upon how many copies do you have and whether the conclusion can be drawn, whether it's an SMA patient or an SMA carrier. So this I just put. I think Dr. Sheeba has explained at length, so I don't really need to go into detail. So depending upon the number of copy number variants of SMN2, the life expectancy is also increased. And this is also what you kind of determine in the analysis. I also wanted to touch upon the silent carrier. So when you say that it's a silent carrier, if you say that there is only a 1 copy, it means that that person is a carrier. So there are 3 critical things that we generally look for. This is a position which differentiates the SMN1 and SMN2. It is 840C and this is 840T. Now, apart from that, you can have the non-carrier, which is 1 plus 1. You will have a typical carrier where you have 1 copy which is deleted and you have 1 copy here. And you can have a silent copy wherein both the SMN exon 7 and 8 are sitting right adjacent to each other. SMN1 and SMN2. So how do you differentiate that? We generally differentiate with respect to this position and this position. So these 1, 2, and 3 are the difference that you generally observe in SMN1 and SMN2. So depending upon where the probe is binding, we are able to differentiate whether they are carriers, silent carriers, or not. So coming to the interpretation part of it. So as you can see here, you have the copy dosage quotient as 1 and 0.99, which means that you have 2 copies of each, right? So here you can see that it is 1 and you have 2 copies. Similarly, SMN2, this one, SMN2 is 2 copy. The ratio is 0.07 and 0.07. However, if you have an affected individual, the copy number would be 0. That means here there is a complete deletion. And SMN2 could be 2. And here, if it's a carrier, they can be half. So 0.5, 0.52, and 0.548. So it shows that you have copy number of 1 and SMN is 2 copies. I would also like to, kind of touch upon amplicon sequencing because there have been occasions that we find that there is a deletion, a heterozygous event. So we end up calling them as a carrier, even though they show phenotype. But that could be attributed to a specific variant. It could be any variant, frameshift variant, which has been, this particular variant has been previously reported. So amplicon sequencing is being used. It's a method of sequencing that targets specific genomic region to study genetic variation. And oligonucleotide primers are designed to amplify specific genomic regions of interest using long-range PCR. The PCR product is further amplified using specific set of primers. Since this is a highly targeted method, it is able to only amplify the gene of interest with high sensitivity. Hence, we are able to kind of determine if there is a variant in specific region. So, like Dr. Dr. Upma mentioned that there was a study wherein there was a case wherein the patient had already got a genetic report. So here also we have found one case wherein there was a family history of a previous child who was affected and he was genetically diagnosed with SMA. So now the fetal sample was sent and the parents were confirmed carriers. So unfortunately, this particular fetus also happened to have a homozygous deletion. Hence, it was reported as pathogenic event. So these are the tests that we offer. We have SMA as a genetic gene analysis. We have the gene panel. We have deletion duplication analysis, and it is also a part of carrier screening tests. That's it.
Thank you, Dr. Sandhya. And I would request comments from Dr. Sunita. Dr. Sunita, you can stop your screen sharing,
Yes.
Dr. Sandhya.
Yeah, hello. Very nicely presented, Dr. Sandhya. It was really nice. Just wanted to give a little clinical perspective. So when we ask for a lab to do the test, we think that this deletion test will pick up the diagnosis. But sometimes it is true, but not all the time.
Correct.
So that's why the deletion part is only present in about 96% of the patients, and the
Yes.
rest of the 4% require more testing. And it
Yes.
is really the clinical acumen that leads you to the diagnosis. And
Mm.
then, of course, like you pointed out, that the difficulties in making a sequencing diagnosis in cases of SMN1 because of the presence of a very similar sequence gene, which is a pseudogene.
Correct.
So a lab has to really work a lot to make a diagnosis. So one must depend upon the lab and have faith in the lab to give you a diagnosis. So it's really important. And sometimes, like Dr. Seema had also mentioned, when we do not have a person or proband who may have died, it's a little difficult to make a carrier testing diagnosis in parents, because sometimes in 2 to 3% of individuals we have more than one copy of SMN1 on one copy, the
Yes.
cis part, and
That's
yet you are a
exactly.
carrier. So
Yes.
when you do an MLPA, you find there are 2 copies of SMN1. However, still the person is a carrier. So it's a little tricky situation. So in our lab, what Dr. Renu Saxena madam has always done is that she has asked for samples of her own parents or the person. Suppose he is a wife, then we do the testing of their parents to see what the segregation is. If the one of the parents has 3 copies, then yes, then we can interpret that the person is a carrier yet with 2 copies. So that's how it comes. I think I will stop here. Yeah.
Can I ask something? Can I ask something?
Yes, madam, doctor.
Basically, what we are told that we look at the copy number of SMN2, but what report says is the ratio. So how to correlate this ratio with the copy number? Because
No, ma'am. It's a
prognostication is
little. So SMN1 is the real gene, and we look at the copy numbers for this to make our diagnosis, whether the patient has SMA or not. And SMN2 is only a pseudogene which helps in giving the severity of the disease.
prognostication.
Yes, the lesser the number of SMN2, the more severe the disease
More
is.
severe, because less is the amount of protein, because that
Yes,
SMN2
ma'am.
provides to 10%.
10%,
So 90% is
absolutely.
by the SMN1. But
Yes,
in
ma'am.
the lab reports, it is written the ratio. It's not written the copy number
So-
of SMN. So that's how to correlate
That-
the ratio with the copy number.
Yes, so the interpretation has to come. That's what Dr. Sandhya mentioned. When they do MLPA, they do take out the ratios and you have to interpret it like that. So if it is 0.5, then that means there is 1 copy. If it is 1, then there are 2 copies, like that. But I think you can also read the final interpretation of the report. It will give you a very simple answer whether the person has 1 copy or 2.
Generally, they would write both. So, the 2 copy also and the ratio also. So generally 0.5 is a carrier, and 1 is the one is the
Normal copy.
Yeah.
And zero is the affected.
Yes, 0 is the homozygous deletion.
Dr. Sunita and Dr. Seema, can I now raise the query again?
Yeah, please.
In the prenatal samples also, are you able to evaluate this SMN2 copy numbers and prognosticate the severity?
Ma'am,
It
our
routine.
primary, yes, ma'am. I understand what you're asking. It's a little tricky answer because we are here as a prenatal laboratory to give a diagnosis of SMA. So regardless of the copy number of SMN2, it is the SMN1 which will give you the diagnosis. So many a times it is not required to do SMN2. But it's if we do MLP, it is the same test that will give both the answer. So invariably, you do get the results of SMN2.
Okay.
But you do not have to bother about this. If there is SMN1 0 copies, that means baby will have SMA.
Yeah,
So
that's why all the obstetrician, the reason probably she's asking, because that's what they are getting confused. They are getting
So I
SMN1.
want to clarify after
Yeah.
this,
Yeah.
after
So
sure,
you look at
clarification,
only
very valid
SMN1.
point.
You look at
that-
SMN1 only. And
yes, as
it should be,
obstetricians,
yeah.
we are not concerned with SMN2. We are primarily concerned with SMN1, and
Yes.
SMN2 is more important
I
in
think the
children.
lab should be more clear about it.
Yes.
Dr. Sandhya,
Second,
to make note
SMN,
that
Yeah.
SMN1 should be highlighted, and then maybe in small font or something below that you can mention.
so
But
there are two
all
important
labs
things.
shows 1 and 2
There are
at
two
a
important.
similar.
No, actually,
And
you can
we
learn
don't,
like this. You
we
can
give a
understand
clear
like this.
answer.
Ki one copy is a carrier in thalassemia also,
Yes.
right? So one copy is a carrier in SMA also. If you have 2 copies of thalassemia gene, then you are okay. Here also, if you have 2 copies, you are okay. But here, because of the complexities of the molecular genetics of this, you can have 3 copies. You can have, the more the merrier. Yeah. So
Yeah.
as long as an obstetrician gets 2, 3, 4, it's okay. You have to look at only SMN1.
But they have exon 7 or 8. Most of the
Yeah,
labs,
exon
right?
7 and 8. Yeah.
So
For
that
both,
makes
you
a
have
more.
to look at that only. 2 copies. So 2 or more, serves your purpose that this is not a carrier or unlikely to be carrier. 2 can be a silent carrier, but I think you can just forget for the time being. 2, 3, 4 is a non-carrier. We will take up these cases, right? 1 is a carrier, like any thalassemia. You
Can
have
I
only 1.
ask this amplicon she was talking about? Can you just explain again?
Yeah,
Amplicon.
Dr. Sandhya?
Yeah. So what we generally do is, as we kind of mentioned, that there are only few bases that are different between SMN1 and 2. So you make a specific amplicon, a long range PCR for that particular region, and you amplify either SMN1 or SMN2. So you have a specific for SMN1, assuming. Okay, so your long range PCR will be of SMN1, and further down that becomes your template, and then you have multiple primers which binds at different regions, and then you amplify it further down. So your sensitivity increases manifold. So you are able to specifically say only for SMN1 that this particular mutation has been detected.
And both are in chromosome 5q, what I understand.
Yes.
Dr. Vanna, just to simplify, because there is a lot of sequence homology, the NGS will not pick it up. And that's why you either need Sanger sequence or you need such kind of measures to separate out the 2 genes, SMN1 and
2
2.
genes.
Yeah.
I understood. So because of the duplication, you can't simply rely on conventional.
So I'll just like to add one statement. For fetal medicine people, it is primarily the SMN1 gene which will discern the exact status of the fetus, and the status of the SMN2 is more important post-delivery, where you want to classify
For the child.
where you want to prognosticate according to the SMN2 copies what the child is likely to present as
Whether
phenotype.
type
I
1,
hope that-
type 2. Yes.
and for all the fetal medicine, please don't venture into the prenatal diagnosis without the help of your geneticist. This is very, very important because these minor details we may not know and we are likely to make a mistake sometimes. So any prenatal diagnosis
So
should not
pre-test
be
counseling, post-test counseling by a geneticist is
must,
very, very important.
must.
particularly in prenatal diagnosis.
Yes,
For
yes.
my clinical experience, I think we should look more at, rather than the number, whether it's a homozygous or heterozygous deletion. With
And
heterozygous, then it's a
homozygous means
carrier.
zero copy.
Carrier,
Homozygous means zero copy. And hetero
homozygous
means
means
one
zero.
copy.
Then
And-
it is a affected.
Yeah.
And we should not forget the compound heterozygote also.
I don't know.
In
It's
rare
there or not.
cases.
It's there. Rare,
In
never
SMA.
seen.
Right. Thank you.
So with this, we move on to the panel discussion. I'll just share my screen. Just give me some time. Can you see my screen?
Yeah, we can see.
Yes. So now we move on to the last session of today, and this is the panel discussion. So whatever we have learned, we are going to revise again, the 0, 1, 2, and 3, 4. And today, along with me, my co-moderator, Chanchal could not join. So Dr. Vrunda will be taking her cases, and we'll be discussing about the carrier screening, newborn screening, prenatal diagnosis, and also PGTM, which few cases have undergone this. So this is the first case, and this is a 13-month-old boy who complains of unable to stand with support. Like by 1 year, they are able to, stand and walk also, and paucity of movements of the lower limbs. So mainly the lower limbs are affected. And he was a normal, born by a 3 kg birth weight, so no problem. And her neck holding was more than 4 months. Crowling started at 6 months, and he was able to swallow the and their semi-solids, and there was no intellectual disability. On examination, there were areflexia in the lower limb, no tongue fasciculations, no chest retractions, CPK was normal. And because of the significant tongue fasciculation gives you a leading diagnosis about the SMA. And this MLPA was done, and which suggested that there is a homozygous deletion of the exon 7 and 8 in the SMN1. And along with that, you can see here, and of course, this is mainly for the pediatrician or those who are into the therapy, the SMN2. So the homozygous deletion deleted in the exon 7 and 8 of the SMN1 gene in the clinical sample tested, and this is indicative of the SMA affected. No deletion or duplication were detected in the exon 7 and 8 also. This confirmed the diagnosis of SMA. So Dr. Vrunda, just revise the what is SMA.
Thank you, ma'am, for giving me this opportunity. So as we all read again and again, we are again revising this. So it is an autosomal recessive disorder characterized by progressive degeneration of spinal cord motor neurons that leads to atrophy of skeletal muscle and leads to overall weakness in the babies. It is caused by a mutation in gene known as survival motor neuron gene, SMN1. So because of this severity and relatively higher carrier frequency, there has been increasing interest in these carrier screenings. So the incidence is actually 1 in 6,000 to 1 in 10,000 overall world. Carrier frequencies in most populations are from 1 in 40 to 1 in 60. So in India, it is 2.5%.
Yeah, so this is the child with SMA. And types of SMA, Dr. Vrunda, we just quickly, just to revise, 0 to...
So 0 to 4, right? So 0 is prenatal onset. So there'll be severe weakness, maybe respiratory failure and death. SMA1 is less than 6 months of age of onset. Median survival 8 to 10 months. There will be some control of head and sitting with support. SMA2 is 6 to 18 months, means less than 18 months. 70% are alive by 25 years of age. Independent sitting is there, but progressively they lose their muscle strength and it leads to proximal muscle weakness. SMA3 again, more than 18 months of onset. They have a normal lifespan. They have independent ambulation, but they also have like progressive proximal muscle weakness. So SMA3, 4 are basically, they have a normal lifespan. SMA4 is in adulthood. So still they have some proximal muscle weakness and fatigue.
Yeah. So this typing is based on the SMN copy number. As we can see in the prenatal onset, there is just one SMN2 copy. And actually there is no case reported of 0 SMN2. Then in the type 1, which most of the obstetrician will come across, where the child will die within 1 year, and there they would say that there is a 2 to 3 copy number of the SMN2. In the type 2, there will be around 3 copy, and similarly, it will keep on increasing. So the more the number of SMN2, because this is a disease modifier gene, so the severity will decrease. This is a case of type 3 SMA. He has not come to me for the diagnosis. He was already clinically diagnosed in the childhood that he is a case of SMA, but no molecular testing was done. And we can see here that he is affected because the copy number is 00. And this is a homozygous deletion of SMN1, both the exon 7 and exon 8. And in SMN2, one can see here that we were expecting that there will be 3 copy, 4 copy, because he is a type 3 SMA, but he also has only 2 copies. So there may be probably more than, SMN2, there may be more disease modifier, which Dr. Sheeba has already highlighted. And we can see here, so this is the SMN1, exon 7 and 8, which is 0. And this is the SMN2, which is the 2 copy number variations, 2 copy numbers. So, Dr. Vandana, just again, we are just revising only, and some so.
Yeah, so just to clinically remember, you can have a non-liver and liver, and the one who live can be non-sitters, sitters, and ambulators, and normal. So
Yes.
that makes the memory.
Yeah.
Okay, so we are again going through the revision that this is a critical region and the chromosome is on the 5q region. And what is so special about this area is that there is that inverted duplicated region. So you have a gene and you have a pseudogene. So you can see as you move from the towards the centromere, this is the pseudogene. And so if the gene is like 1, 2, 3, 4, 5, 6, 7, 8, then the pseudogene is like 1, 2, 3, 4, 5, 6. So it's in the duplication is there, but it is in the inverse. So you can see this area has these genes GT, F2H, NAIP, SMN1, SERFI1, and on the pseudogene side, you have the SERF1B, and what is of interest to us, the SMN2, because the presence of the number of SMN2 decide on the prognosis, and then you have these other 2 pseudo gene areas. So this makes this area interesting, and this is the reason why we spoke about more specific tests to map this area. So SMN1 and SMN2 gene both contain the same number of exons since they are duplicated, but there is only that one difference in the C to T, as we have just seen, that is making the difference. The base C at the 6th position in exon 7 and SMN1 has been determined as an exon splicing enhancer, and as mentioned here. And however, the transition from C to T at the 6th position in exon 7 and SMN2 disrupts, leading to the majority of the alternative spliced SMN2, which doesn't form the protein as well.
Yeah, so with the molecular genetics, now we move on to the clinical and molecular diagnosis. So, Dr. Veronica, are you there?
Yes, ma'am. Good evening.
So, thank you for joining, Veronica. So, you can go ahead with how do you suspect these children in the childhood, in the infants, the infantile, and the.
Yeah. So SMA is rather easy diagnosis to pick up. So we look at floppy infants, the infants who have very less tone, and there is an absence of reflexes. So a floppy infant with absent reflexes and tongue fasciculation is something that is pathognomic of spinal muscular atrophy, which is type 1. But of course, all the patients do not present in the same way. There are very reduced movements in some children. Reflexes have been seen to be present in some type of SMA also, which is known as SMA with preserved reflexes. The lower limb is generally more involved. Proximal symmetric muscle weakness is present. So that is about the infantile SMA, and these children generally never sit the SMA type 1 if without therapy. So as we discussed, in the childhood, there is proximal muscle weakness, which is predominant as compared to distal muscle, tongue fasciculation, tremors, and all this is because of the involvement of the anterior motor neuron. And the diagnosis of SMA, I think we've discussed multiple times in this webinar, so maybe, ma'am, we can let it go, right? MLPA is a test of choice. Someone had asked in the questions as well. For carrier screening, also, you cannot do Sanger. MLPA is the gold standard, the test of choice for all kinds of SMA.
There is a diagnosis in doubt, and there is one diagnostic algorithm given in the gene reviews, which Dr. Sandhya has already highlighted. So, would you like to just summarize, Dr. Veronica?
Yeah, so I think we have spoken about this algorithm. So, what this algorithm really summarizes is that the first test you do is MLPA. You can also do a PCR. PCR is a cheaper test to do. So, antenatally, sometimes it is a good idea to do PCR, because if your PCR shows that there is homozygous deletion, you can go ahead and terminate. But when the child is living, it is a better idea always to do MLPA. So, you also get the SMN2 copy number and know what type of SMA you're dealing with, and related to therapies as well. If the suspicion is very strong or you get one copy deletion, you go ahead and perform SMN gene sequencing. The method to perform SMN1 gene sequencing is never an exome or an NGS based testing due to the presence of a pseudogene. So perform Sanger sequencing for SMN1. If you're still suspecting SMA, then maybe you're dealing with a 5q SMA for all of this, non-5q SMA for all of this is negative, and then you can go ahead and do maybe an exome sequencing or panel for muscular dystrophy.
Oh, so this is already there. So now, Dr. Vrunda, I would request you to go ahead with the carrier screening. So
yes, ma'am. So carrier screening, reproductive carrier screening became possible in 1970s. Initially, this was by biochemical tests, differences in blood test parameters that allow them to be identified as heterozygous. So we do carrier screening for hemoglobinopathy like thalassemia, sickle cell anemia by CBC and HPLC. Tay-Sachs disease is by enzyme assay. In late 1980s, it became possible to identify carriers by genetic testing. Those were diseases like cystic fibrosis and again Tay-Sachs. Ethnic and pan-ethnic diseases were hemoglobinopathies, which were common in Mediterranean regions, Africa and Asia. TSD was common in Ashkenazi Jewish communities, and cystic fibrosis in European descent. With the advent of massive parallel sequencing, also called next generation sequencing, carrier screening has become possible for hundreds of conditions relatively cheaply. So as we know, we know that everybody knows here much more than me that what is autosomal recessive inheritance. So carriers are healthy if both parents are carriers, 25% risk with each pregnancy, males and females are equally affected. So these are most diseases which we see are thalassemia, spinal muscular atrophy, CAH, and cystic fibrosis. So options for carrier couples, Dr. Manisha ma'am, can you just take this question?
Yeah. So basically, I would like to thank, before I go on to this, thank Dr. Seema and the whole range of experts who have really, it has been an eye-opener, this webinar. So whenever there is like a carrier couple, you need to first do a genetic counseling, especially in disease such as this, in which there are multiple aspects. I think it is best to refer to a geneticist if anyone feels inadequate, and the genetic counseling. And then there is a prenatal diagnosis, which we generally do when the parents are carriers. And so what are the options? So generally, whenever we do prenatal diagnosis, there is always a more chance that the baby will not be affected. This has to be communicated. And even if they have a very bad history of having 2 or 3 repeated losses, then maybe you can go for donor oocyte or donor sperm. And then, of course, pre-implantation genetic diagnosis is an alternative. And of course, you should always bring adoption into your ambit whenever you're giving a counseling.
So when is the right time to get carrier screening, ma'am?
So whenever the best time is preconception. So whenever patient comes to us, we always ask whether she's pregnant or not, because that relieves much of our stress of the running against time thing. So preconception is the best time. And then of course, antenatal early pregnancy, because when when the patient comes early in pregnancy, you can do CVS, you get a better tissue for DNA diagnosis. So, and you get early diagnosis also. So these are the advantages of doing CVS. And of course, if the patient wants to go for IVF, before an IVF procedure would be the best thing, because you can do a PGD also at that moment.
Yeah.
So we start with the case here.
Ma'am, can I just add one small thing here? So, a lot of times it is discussed to get this testing premaritally. I think that is something that should be discouraged, because we are not here to really make matches on the basis of genomes, and the best time really is preconceptionally. So, that as a community, it's best to say to not conduct carrier screening test and label and mislabel people or create a bias like that.
Yeah, very rightly pointed. Our society is not accepting premarital in a good way, in
Especially
a
X-linked
positive way.
disorder.
But if there's a family history of affected child, if there's a family history, because
preconceptionally will work, no?
Okay, you're saying even family history, you wait till you get married, then you get it done.
Yeah, in our country, the timing to do the carrier screening is early pregnant, post marriage only. So premarital counseling is not working because our social structure is not like that. Our population is not that educated, and even if they are educated, there is lots of stigma related to the genetic disorders. So the moment they find that the girl is even thalassemia carrier, they say we will find out some other girl. So it's mainly for the discrimination. It's better to stick to the carrier testing, to the early pregnancy, and that to the post marriage only.
And it is not like thalassemia. Like in thalassemia, the trait will have the problems. Like they will have, they will have a slight mild anemia, and they might have a high ferritin. It's not like that. So especially in this case, maybe it is not worth it. Maybe the husband doesn't have the problem. So it's always good, Veronica. Nicely pointed.
So here was a case of a 6-month-old boy with decreased limb movements. Genetics tests confirmed SMA. And the boy was started on Zolesma, which costed 18 crores. And this boy was conceived by IVF. So carrier screening, as we know, is only 4,000 to 5,000 INR per person. So what are the recommendations, Dr. Veronica, for carrier screening in such cases?
So, the Indian Society of Indian Academy of Medical Genetics has now released the guidelines for universal screening for SMA in all patients, for all women, regardless of their age or ethnicity, and irrespective of other carrier statuses, because of the high frequency of disease in India. So, both partners can be screened simultaneously or sequentially. And I think because the test is a little expensive, it is not a bad idea to screen one person with SMA. But even if one person is normal, there is a residual risk of about 3 to 4%, because there are other mechanisms as well. So, in short, we need to screen every pregnant woman at or before pregnancy for spinal muscular atrophy.
So can I ask why it is different for thalassemia and SMA? Both are autosomal recessive. In thalassemia, we say if mother is carrier, then you go for the partner. Why in this both together?
Ma'am, because there is another mechanism of disease in SMA. SMA can also be caused by sequence variants. So if you're testing one person and not testing the other, then you may be missing the sequence variants in the first person. Thalassemia, HPLC is a very high sensitivity test for thalassemia. And also in thalassemia, ma'am, we see that if there is a person who has borderline HPLC and one person has a high HbA2, then the other person can be a silent carrier also. So for both, it is definitely better to test both. But we test one in most conditions, but now we are offering SMA to all our patients who come at least to the genetic clinic.
And so we must offer both together because the risk of being silent carrier is higher here compared to the thalassemia. And there is no way to suspect. Like in thalassemia, by looking at microcytosis, probably you can suspect that this person can be a silent thal trait and you can go ahead with that. But in the SMA, there is no way of any biochemical test for SMA. So, and the incidence of, as per which Dr. Sunita was highlighting, as per Dr. Verma's paper, the incidence of two copies is higher in our country, and this 2 copy can be 1 each. That's what we presume. But very occasionally, this can be both the copies of SMN1 can be on one gene only. Right, the 2 copies means one gene, right? But in many cases of SMA, there can be both the copies of SMN1 on one gene only, and the other will have 0. So this person, if transmits that 0-1, then and the other person also has got similar. So that's why the incidence of silent carrier is difficult to predict here. So that's why we try to make sure that it's best to test both partner, but if cost is a concern, we can go ahead with the one only.
And there can be new mutations also, Seema?
Yeah, the new mutations. Yeah, that's why we say the residual risk. You know, the 96 to 95% only can be checked by all these deletion MLPA.
Seema,
So
I want some clarification.
Yes.
If mother is the silent carrier,
yeah,
we say she's not a carrier, apparent carrier on her
Then
report.
no chance of transmission.
No, then even if we test the partner, how are we overcoming that small fraction which you say one can miss on single testing, that is only testing of the woman? I'm not clear with that. So
because if mother is not affected, then definitely it's autosomal recessive. If father is affected, then
no. Like there are
it can't be
genes
passed
for
to the
anything. It's a very simple, doctor. I'm trying to I can explain. I think I may be able to explain you. So there are 2 genes of SMN, right? Right. So sometimes it happens, and we expect that in one on each chromosome, right? On chromosome 5, we may have few women where both the copies can be on the same chromosome.
No, I got the concept what a silent carrier means, 2 plus 0.
Yes.
I got that. But on routine testing, we are likely to miss these silent carriers, no carriers.
Yes.
Then how the testing of the husband helps us to
make you suspect is what she's asking. How like how the lab will tell
Clinically,
us.
we cannot suspect because probably the residual risk will be less when we test both compared to, because the one Indian paper by Dr. Verma says that the incidence of silent carrier is probably higher in India.
No, but can I add something here? I'll just add something. So, ma'am, what we do is that if we have one person who has 2 plus 0 and the other person who's a carrier, then we tell the patients that this is your risk. 2 to 3% is your risk for having a child for being a carrier. So, if they want, we can offer prenatal diagnosis. If they want, we can offer prenatal diagnosis based on that 2 to 3% risk. If they want to be even more sure before they want to carry out prenatal diagnosis, the other way is to test the parents of that person who is a silent carrier. So when we test the parents of the person who's a silent carrier, that person will have maybe a 1+2 or a 2+1 configuration. So that will prove that the person is a carrier. So we need to go ahead in one generation, test the parents, and then prove. If they don't want to do that because the pregnancy is ongoing, they can undergo a prenatal diagnosis, because that is short way of determining the.
So in the silent carrier, the risk of a baby being affected is 2 to 3%, not 25%.
No, ma'am. No. That person being a carrier,
risk.
The person being a silent carrier is 2 to 3%. So the chance of baby being affected is 25% of 2 to 3%, which is even lower. So we need to counsel them in such a way that if this happens, what will be the risk? Most people would not want to do prenatal diagnosis for such small risk, but some of them do, and we test the parents, and testing the parents, we can a lot of times find out if the person who's supposed to be a silent carrier is actually a carrier or not.
Thank you, Dr. Veronica and Dr. Seema. I
Same.
think now I'm clear with what you are saying. Dr. Sunita wants to say something. Can we
Yeah,
listen
Yeah,
to
please.
her
can
also?
I,
Yeah,
can
yeah,
I, yeah,
yeah,
thank you.
please.
So I think what I've got from the discussion is the question is if you're just testing one partner in a couple for a carrier status and that person has to have two copies, then how sure you are that she's not a carrier, right?
Yeah.
So basically, the idea of doing the second partner is to reduce the chances of the carriership, right?
Yes, the
Because the
residual risk.
chances of the second partner also having 2+0 configuration is very low, right? So the combination is very, very low. So you are just reducing your chances of them being carriers. You are not eliminating the chances. This is actually true for any carrier testing.
Yeah.
So,
So,
and
it
I
will
don't think,
assure more.
I don't think we can offer a prenatal diagnosis just based on an assumption that it is a 2+0 carrier and the other partner is not tested. We
Yeah, we
have to
should
do
know.
carrier testing.
Yeah.
And one more question, please. By doing a carrier screening, are you able to make out this 2+0 or
No, ma'am, the
Have,
parents needs to be tested.
Yeah, Dr.
yeah.
Sandhya was highlighting something. So, are you around, Dr. Sandhya?
Yes. So I think we have to rope in geneticists. We can't.
that should
Yes,
satisfy?
SMA carrier testing is little tricky, but just we want you all to learn that two and more is not unlikely to be a carrier, right?
Dr.
Yeah.
Veronica, I just want to clarify, even if one partner is tested positive as a carrier,
Yes.
other we are not getting anything, still we can offer prenatal testing.
Ma'am, so what Sunita ma'am said, we
If
shouldn't,
there
but
is
a
a
lot of
family
times we
history,
just
if
add
there is a
testing.
family history, if there is a previous
Yes, if
child
there is
who
a
has
family
it,
history.
then you will. Otherwise, you will not. Otherwise, you will try and get the carrier status. You will do the Sanger. You will do the amplicon assay in the NGS. That's how you do.
So for the second person sequencing by Sanger, and if they're still not happy with that small risk, then you test the parents, but we should be sure that they're a carrier before testing.
Yes,
And one more
but for all practical purposes, till now we are offering prenatal when both are carrier. If
Yes.
one is a carrier and the other is 2+0, we tell them the residual risk truthfully that there may be a chances that this baby may have of SMA, and if they want, they can go ahead with the prenatal or further testing.
This is true when there is no affected child, previous affected child. This is what you're saying, Dr. Seema, is when there is no
no
history
previous
of previous
affected.
affected.
No previous affected child. If there is a previous affected child, that means that she is a silent carrier. She has already proved. There are
Yes.
few cases of SMA like this who had 2+0 and the other partner was a carrier. Then later on the child was found to be SMA, and that's how retrospectively she was diagnosed that she is a silent carrier. So it is a mostly retrospective diagnosis in case of affected child. But when we are making the prospective diagnosis, for us, the knowledge of 2+0 is more than sufficient to assure them that 2 to 3% is only the residual risk, and testing simultaneously, as Dr. Sunita also highlighted, and I'm also again re-emphasizing, is just to reduce that residual risk, because our Indian paper, again, the same paper that says that probably the incidence of 2+0 is higher in our country. So that's why, so you can discuss with them. They can want one or they can want both if the cost is a concern. But doing two together is the best option, what I feel.
No, I have one more
Agreed.
question. Can I ask that?
Yeah,
Yes.
please.
So we have done a carrier screening and we are, say, they are both carriers, presuming they both are carriers. Is that carrier screening good enough to do a prenatal, or you do need to do some interim testing to define exactly what the mutation or whatever it is?
No,
No, that is the mutation only.
That is deletion. Yeah, mutation.
no, that is the mutation.
So you are doing carrier by MLPA or maybe
Only.
advanced testing if required, and that's good enough even to
Carrier
carry.
testing, we don't do NGS or Amplicon. Carrier testing is only by MLPA. That advanced testing is for the index case diagnosis. The gene
All right.
diagnosis algorithm gene review,
All
that
right.
was
And
for the
so,
index case diagnosis,
and
not for the carrier.
how good is QF-PCR for as a primary test for screening?
UFPCR is equally good, but not, most of the laboratories are doing MLPA. It's just the
And how
method
long does
that a lab
MLPA
adopts.
take? The turnaround time,
Turnaround
usually
around
PCR is 3-4 days or maximum a week. And for MLPA, I
MLPA
think
10
it's
days,
longer.
10 to 2 days.
Dr. Sunita or Dr. Seema,
It
if
depends. It depends on the lab. Dr. Seema,
Yeah.
you want to take?
No, the TAT is, for the QFPCR has to be smaller, like, 5-6 days. But MLPA, generally, they would take 10 days only.
10 to
So we
12.
tell them 2 weeks.
So
1
I
week,
think
2 weeks.
message should go, this expanded carrier screening has to be done for the couples,
Yeah.
only married couples.
Yeah, married couples. And
Only
That should be
couples,
the
whether they are
message.
married or not married.
They should be couple.
I,
They should be couple.
highly say.
Who are planning
Yeah.
pregnancy, who are planning pregnancy together.
Yeah. So
Can what all tests are being done in expanded carrier screening? Can we get
yeah,
a what?
Veronica, this is okay. This was Dr. Vrinda's question only. Okay, so what is expanded carrier
So-
screening, Dr. Vrinda?
Expanded carrier screening is any additional genetics testing other than universal screening. So who should be offered this expanded carrier screening should be offered only after consultation with a qualified clinical geneticist. Pre and post test counseling are always mandatory for any screening tests. So there are basically three main conditions where we offer this expanded carrier screening. Where there are the couples with a family history of suspected genetic disorder, in which diagnostic testing is not possible because the index case or probands died, or unavailability of probands biological sample. Other things are consanguineous families who seek preconceptional counseling just to avoid autosomal recessive conditions. In special situations such as bad obstetric history, where there was an unexplained stillbirth, or any fetal malformation suggestive of monogenic etiology where fetal sample is not available. So carrier screening of spinal muscular atrophy in North Indian population and its public health implications. This was a study conducted by Verma et al. In 2020. So 400 women were studied. Carrier rate was around 2.25%. So SMN gene copy number variants were shown as this. The subjects were, as I told you, there were 400 people. So there were SMN gene copy numbers, as we are seeing, 2 copies were present in 88.5%. So silent, including those of silent carriers.
So that's why we, highlight this. And so the moment you get 3 and 4 copies number of
Then we are
SMN1, and this is all we are talking about SMN1. So
One.
if you get more than 2, then we must be sure that this is 2 plus 1 or 2 plus 2. So at least it's not 2 plus 0. Then there are lots of Indian studies, actually. This is one done in North Indian population. Surprisingly, I didn't find any South Indian population. Maybe Dr. Sandhya can work upon it. And this is by Dr. Mayank Nilay, and they did 626. And they also found something around, 1 in 338. So we have carrier frequency of SMA as around 2 to 3%. Yeah, and this is 1 in 30 again. This is again North India only from so genetic tests for SMA. I think that has been taken up again and again, and that is the most commonly available. That is the MLPA test for, and this is you will get report like this. So this is, we have to, as an obstetrician, the interpretation would be like you have SMN1, you don't look at the SMN2 basically, and these are two copies. So this, and here also you can see here that this is near this one. So this means that there are 2 copies of SMN2. So normal SMN1 exon 7 and 8 unlikely to be a carrier. Then there are different situations of the carrier testing. And here we can see, first look at the numbers which are written, rather than looking at these graphs or these figures. So if you can see here, SMN1, exon 7, 3 and 4, then unlikely to be a carrier because this is 2 plus 1 or 2 plus 2 combination. Then the another situation is that the one which clearly says that this is a carrier. You can see here the copy number is 11 for SMN1 only. So SMN1 exon 7 and 8, one copy each, and so this person is a carrier of SMA, and the partner needs further testing for this. This is just an interesting McKenzie mission, and how this led to the Australian reproductive genetic carrier screening. And so in 2017, this is a couple, Mackenzie Casella. This is the daughter's name, the daughter of Rachel and Jonathan Castle. This is very interesting. That's why I took up this. The child died at 7 months of age from spinal muscular atrophy. So she was having type 1 and autosomal recessive condition for which her parents were unknowingly genetic carriers. So the Casellas had not been made aware that there is a reproductive carrier screening for spinal muscular atrophy was possible and available before or during their pregnancy. And since then, the Casellas, this couple, has been vocal advocates for the reproductive genetic carrier screening, and just SMA was led to the Australian government to launch this project for this reproductive genetic. So in 2018, it was announced that the government would fund a large national research study, which was named after the child, that is the Mackenzie, and that's why the name is catchy, the Mackenzie's mission, the Australian Reproductive Genetic Carrier Screening Project. And this has got 2 phases. Implementation needs were mapped in the phase 1, and then in phase 2, these were this was offered by the healthcare program, and the results are published. So now, Dr. Vrunda, the prenatal diagnosis.
Yes, ma'am. So this is a case where a 26-year-old gravida 2 para 1 came at 6 weeks. Her previous child was affected with SMA, so which was confirmed by MLPA. So Dr. Vandana ma'am, do you need parental carrier testing in this?
Yeah, so I think it's always nice if you can confirm with the parents, because that kind of closes the situation and makes things easier. Also, I think there is this whole concept if you test the parents, then it's easier to suspect the siblings also. You would know could be. So again, I bring up that debate about premarital testing, because if you have an affected known carrier person, and they have siblings, so I think even before marriage there is that concept of screening the siblings. And then there's always the concept of paternity, non-paternity, and it is helpful if you know the mutations, I think.
And also there are 2 to 3% de novo cases of SMA, that the person is entirely normal and still they will have this deletion in
De novo.
Yeah, that would be.
That's why it's better to test, because many a times I am asked this question कि MLPA से तो confirm हो ही गया था, parents के test की क्या जरूरत है, बहुत these are the
extra cost for the parents.
Yeah, but it is justified, Dr. Upma. So I think you can convince so that's why I took up this care,
So in our case, we got it done, but I was just wondering, we had the molecular testing of the proband, why we got
now you got the answer. It could be de novo also.
De novo, it's more in dominant, but definitely recessive may also can.
Yes, ma'am. So Dr. Manisha ma'am, can you just elaborate on the methods of prenatal diagnosis and screening?
So as I've already
In
mentioned
general,
in the previous thing, we have already mentioned that doing a chorionic villus sampling is the best if the patient comes early. Otherwise, you can do amniocentesis, cordocentesis, anything. And because it gives good DNA yield for the testing. So this is how the CV is.
This is Vrinda's case only, Dr. Chanchal.
Yeah.
So this is Dr. Vandana, can you just, the cost, the abortion in general, this is not specifically to SMA.
So generally speaking, any disease which we are testing for prenatally, if it's a DNA-based diagnosis that we are making, then it's always nice to have a early on CVS sample. And as you can see here, we go in typically between 11 weeks to 13 weeks, 6 days, and we can go in and pluck out the villi there. And from there, we can extract the DNA of the fetus, and you can do the test of your choice. The cost obviously depends on the center where you're doing, but as mentioned here, it could vary from 10,000-15,000 to 25,000. Risk of miscarriage, now we generally consider it almost identical to amniocentesis as we go along the experience.
So there is no need to, scare for the CVS because the both are equally
Equal.
comparable as far as the risk of complication. And done in experienced hands, it's all OPD procedure, so all about to be safe only. So thank you, Dr. Vanda. So this is the case, Dr. Vrunda.
She is a 24-year-old, 28-year-old lady, gravida 4, para 2, abortion 1 at 6 weeks. She came. First female died at 7 months of age. Diagnosis was SMA. Second, PND was done. Fetus was affected. Thus, it was terminated. Third, IVF with PGTM done. Postnatal, baby affected. Fourth is the current pregnancy. So, do you advise amniocentesis, ma'am, Manisha ma'am, in every post PGTM case?
Yes, so even if the PGTM has been done, we advise amniocentesis for confirmation. It should be counseled that way.
That's what was missed in this case, and unfortunately, this baby was again affected. So this lady was so much moved by this error that in the last pregnancy she came with a donor IVF, and still she underwent I said, see, with a donor IVF you are not going to get this procedure. This you don't need this. She said, no, I want amniocentesis. So she came for CVS actually, but I tried to avoid. So I said, there are lakes, they are bleeding, because I didn't want to do this. But then she again came back for the 16-17 weeks, and we performed. And this time, because this was donor, so this was not affected. And also she wanted to know because the IVF mix up, so she wanted to know that also. So fortunately there was no IVF mix up also. So
But one question here I want to ask, ma'am,
Is
whether
it
it is
legal to do IVF mix up now at this point?
No,
Because
I don't want to say. No, she wanted to know these days they would want to know that also, that so if you do maternal cell contamination, you will get to know, even if you don't ask, right?
Here,
Yeah, you will get to know. So this is like Dr. Vrunda, you were saying something.
No, I just wanted to ask one question here, ma'am, that when it is a donor with as we are saying, SMA has high carrier rates. So will the donor be tested for SMA before?
Yeah, the donor was tested. Yes, in this case, the donor was tested.
If the indication for taking a donor
can have de novo, so she got the
is a
fetus
single
tested.
gene disorder or something, donor has to be tested. Otherwise, the whole purpose.
Yes, ma'am. Yes, ma'am.
Is lost.
And in fact, these are the people who should be screened for thalassemia and all also.
Yeah.
So one more question I want to ask. If we are doing amniocentesis or CVS for any other indication, do we tell parents that we can send a common for SMA testing also? Can we counsel the parents for an SMA testing?
I think we have started doing, Dr. Vrinda, and I think Gangaram also does, because we have we have learned by burning our fingers, because we did CVS for thalassemia, baby was not affected, and after birth they called me and they said that the baby has got SMA. So this is not one instance. I had 3 such cases who came back and told me that you did amnio or CVS, now the baby. So I have started offering the add-on SMA after any microarray testing or any single gene testing. I do offer them, and you will be surprised that more than 70-80% couple would accept this add-on testing for SMA, knowing so you have to explain them, convince them, and then they would go ahead with the testing. So you rightly pointed out that we must start offering, even not only as a carrier testing, also as any post
because anyhow we have a fetal sample then, so why not get tested?
Actually, Dr. Vrunda, we are doing QF-PCR, but we are doing QF-PCR who are not affected.
Yes.
So similarly, SMA can be offered when the baby is not affected by thalassemia, as in this case.
Yes.
So I think we can document.
Dr. Seema, I want to make a clarification. If we are doing a invasive procedure for, say, a high risk screening
on dual,
are we offering thalassemia testing also to all that we are?
No, thalassemia of couple from blood.
Carrier screening is foolproof.
Yeah, so we do carrier testing of couple by blood only.
HPLC.
HPLC. Yeah, by HPLC.
If
But
you have
for
normal HPLC of both the parents,
no need, ma'am.
don't offer thalassemia.
No.
Even even if you have not screened the couple for SMA testing, we should
still
offer.
We should offer.
But then you will need the parental sample for carriers. You don't need the
no,
parent.
we don't
No,
need it.
ma'am, we don't need. No, ma'am, we have to just see if there is
One
any deletion
mutation,
of
because it's
SM.
a
Yeah,
single mutation.
We will get to know
deletion.
0, 1, 2 of SMN1.
Okay,
That's
okay,
all.
got
Yeah,
it.
that's all.
Thalassemia
So,
has many mutations, right?
yeah, that is
Yeah,
what
that is
So it's
specific
not
mutations.
easy
Yes,
to offer. Yeah, so
yes, ma'am.
HPLC is the best.
For
And
SMA
for,
trio is not required, huh?
no,
Trio
no,
is
we
not
don't
required.
need.
Only
No.
okay for
That is only required, as a parental, testing for the further future prenatal testing and all. Otherwise, this is not as SMA trio. So that's why the cost is also saved. So if you are doing carrier testing, we do both couples. So it will be double cost, like 10,000. But if I'm doing fetal testing as an add-on test, and of course, add-on I do only after the reports are normal.
Normal. Yes.
normal for the what we are doing for
Yes.
Yeah, exactly. It's not that all together, even if the gestational age is advanced. So that's how.
That
And
means,
one more
Dr. Seema, if we have an indication where we are going to do invasive, then you don't need to check the couple, just do the fetal testing.
Yes.
Yeah, we directly do. Yeah.
So this is something like sickle cell?
No, sickle cell
No,
is
ma'am. Sickle cell again
no.
is
Sickle cell is HPLC testing.
HPLC. Yes, ma'am.
Thalassemia का ही मतलब thalassemia
सिकल
that is
सेल में अगर
hemoglobinopathy
HPLC होता है,
What she means is single
sickle cell,
mutation.
what I mean is that there is a
single
single
mutation. Yes.
Not from that perspective, from mutation perspective.
Yeah,
So don't do a mutation testing in sickle cell. If HPLC shows you that a sickle cell is there, you straight away go for fetal diagnosis, no?
Yes.
Okay.
Acha, there is no need for molecular testing in sickle cell. You can directly
No.
go for
Because it is
HBB
just one
and it will.
Yeah.
Okay.
Yeah. So it's not only the carrier screening, the prenatal testing, the add-on testing. Also, now it's time to do the newborn screening, and again the onus lies on the obstetrician only, because they are the main point of contact for the 9 months, and so they play a big role in the newborn screening. So, but just the principles, the purpose of newborn screening, Dr. Vandana. Just quickly, because we are
running short. So we know that if we know the diagnosis, we can start the treatment early. And if we start the treatment early, only then the treatment is more effective. So it helps if you have screened the newborn child. And these are some of the universal diseases: congenital hypothyroidism, CAH, PKU, etc., which we've been screening traditionally. And then we have the expanded EMS and the
they're very
GCG.
inexpensive, 3,000, 4,000, 5,000, like that. So why we are doing, Veronica? What is the newborn screening rationale for SMA?
So for any newborn screening program to begin, we need to follow the Wilson and Jagner's criteria that the disease should be prevalent, the disease should be a common disease, and that there should be therapy. The test for the disease should be easily available and equitably present in the population. So we now know that we have a very sensitive test for SMA carrier that is now present, but still the whole lot of discussion that was going on, it does not pick up every affected or every carrier. So it is better, maybe if possible, to do newborn screening for that percentage that is missed by the carrier screening.
So
as I just discussed, SMA does meet all the criteria of Wilson and Jagner's, and we have a good test to do the SMA newborn screening.
From the dried stop only.
DBS heal.
And the add-on which Dr. Vandana, which we were discussing. So this is my last slide. So as we know, treatment of SMA is available, but their costs make them unaffordable for most patients in developing countries like us. So therefore, the traditional genetic approaches of the carrier screening and the prenatal diagnosis is the only option. Knowledge about the carrier status will help the couple to make the reproductive choices, prenatal diagnosis, pre-implantation genetic diagnosis. So
I have a question. What percentage of SMA is like type 1, type 2? Like, is it very common to have type 1? Or is it common to have type 4?
commonly,
you have to look at S1 only.
No, I know, but is it very uncommon, the type 4 and 3?
Yeah, generally, I would very rarely would get type 2 and type 3. Probably they are visiting the pediatricians or the pediatric neurologists. So I would
Incidence?
generally get, the type 1 cases only where the child has succumbed within a year. But
They
this
will
case
visit
which I
the
showed, type 3, there were two brothers and both were having this SMA, type 3. And then the second one had married and he wanted the prenatal diagnosis for the next for his child. So we tested the daughter, the girl, his wife, matlab. So then she was a SMN 1, 2, and 3, right? So there was a question: can she be a silent carrier? Then we performed the amplicon gene sequencing. Also, she was not carrier by that also, and so we avoided the prenatal testing. So 3 and 4, I would hardly get, Dr. Manisha. So we would, as an obstetrician, you will only get to see where the previous child was a floppy infant and died within the, sometimes just by the clue, they used to say, the child slips out of my hand. And by that clue only, I got to know that probably the child was hypotonic, because that's how you assess. So, the child was hypotonic, and then we did the carrier testing. And that was the time when the molecular tests were not easily available. So we made the carrier diagnosis by the MLPA, and then they did the
but in the treatment part, I mean, were they not taking those babies only, like those children only who were 3, 4?
Yeah, they are taking, I think, type 2, type 3, Dr. Shefali. They will be
2,
going to them, so we will not get
I mean,
to.
in a society, like in a what is the prevalence? I wanted to know. Like, is
different
it quite
types.
common or
Ma'am,
not?
the
What
most common
I
SMA
want
is
to
type
add.
1. About is someone
Yeah.
Okay, so most common is type 1, ma'am, around 60%, followed by type 2 around 40%, and type 3 around 10, and type 4 less than 5. And the reason why they are in this order is also quite logical. So how do these SMN2 copy numbers increase? There is a repetitive region in the SMN2 which undergoes a duplication event, which is a chance event. So SMN2 copy number should be 2. If they are 3, it becomes SMA3. If
I
they are 4
understand
or
that.
more.
I
Yeah,
just
so
wanted
it
to
becomes
know,
lesser.
like, if we are doing a prenatal diagnosis, then that also, like, that is helping us in the treatment and diagnosing them early and going
Yeah,
the
even the SMN2 also, they would come to us for the prenatal testing. So
Yes.
they come
Yes.
to us for prenatal.
Yes.
So I was just wanted to add, I was reading an article, they said that most of the time the SMN2 type, stage 2 is detected because majority of these babies, they die within, type 1 died within 1 year. So the diagnosis is not made. Who live beyond, mainly the diagnosis is made.
Yeah.
Because
Yes,
they
yes.
of respiratory causes, because they have diarrhea. So many a times type 1, the diagnosis is not made.
But
So
then
majority we picked up.
increasingly the diagnosis is
Yeah,
being
the
made.
scenario is changing because,
because
they would go to the
think,
pediatrician, they will make the SMA testing, and then they will call you that, this was the test, and this has we have diagnosed SMA. So where to send? So for everyone, when there is a SMA confirmed, then there are just two centers for, where we would generally send, the Dr. Shefali and Dr. Gangaram Center. So because these are licensed for the treatment, because this treatment everybody can't do. So only the pediatric neurologists and the the Gangaram has been given this.
So this rare disease society, it gives 50 lakhs, what I was reading. So is it being given to Gangaram and for treating these
For the patients,
babies?
yeah. The Center of Excellence, there are, I think, so
Ma'am,
Dr.
AIMS is a center of excellence, ma'am, in
Even
Delhi.
yours
So
also?
no. So, ma'am, it is a more of a private
Government
government
centers,
thing
yeah.
because of that. Yeah, government hospital. So AIMS is a center of excellence, and now MAMC also, I believe, is a center of excellence for. So over there, we can the 50 lakh that is being given
For
under
the
the
rare
rare
disease
disease
is available.
policy. Yeah, can be given. Yeah.
Or they can approach the Cure SMA Foundation. They are working quite good, that at SMA Foundation. I think with this, I hope we are we have understood 1, 2, 3, 4 in this SMA. like we learned, our counting with 1, 2, 3, 4. So here it is the counting for SMN1, SMN. And so with this, I think we stop here. So thank you, everyone, our chairpersons, our experts, panelists, speakers. So for a wonderful webinar today.
Thank you, ma'am, for
Thank you
making
for
us
inviting
relearn
us.
things.
Seema, we
Yeah.
are looking forward to that CH webinar.
Yes, ma'am. That's what I was also going to tell Sangeeta,
Oh,
ma'am.
I
that
can do, but somebody, the reasons. We are so much paranoid about that PCP-NDT, so we really got scared.
Okay.
So we can do the
Then
local.
maybe,
Yeah, you
then
understand?
maybe in a closed group we
Yeah,
can.
we
Yes,
can do
ma'am.
in a close, because that really needs, there are lots of
Lot of discussion.
insights in that, and we will catch up some molecular
But
geneticists
Dr.
later.
Seema, I must congratulate you on your foresight. I'm really telling you, as a fetal medicine person, I was not aware of so many aspects of SMA. It was only because of your webinar, some in-depth reading, and secondly, this genetic testing has become much more clarified to us. And it
I
is
am an
going to touch
obstetrician,
our
na?
practice.
So
It
I
is,
know what my colleagues don't know. So that's really.
yes. So
No,
it
no.
was
Because I
very
also
Now,
look
important.
at that way.
now we know that we have to refer.
The
So
whole
Manisha, it is
idea
my
was you should
principle.
be able to
Cannot do it.
diagnose.
So Manisha, it is my principle, and I'm fortunate to have a department of medical genetics now. Earlier, it was a genetics unit in MAMC, but even a thalassemia prenatal, I don't do without a pre and post test and counseling from a
That's very important.
geneticist, because I have the privilege. And this was really an eye opener. I think many aspects of genetics which are going to touch the fetal medicine now also.
Yeah, it's like the same. Even we can also do the normal delivery and cesarean section, but we refer to the obstetrician, because those who do their job, they will be doing well. So and I always say that these are the fetuses; they don't know anything. So we have to hand their hold with honesty and sincerity. So it's always good to involve everyone, because after all, this care of the fetus and the mother during pregnancy, for the carrier testing, the prevention is a multidisciplinary, and we must involve clinical geneticist, medical geneticist, so that
The team approach, yeah.
Yeah. So have to the correct diagnosis and the correct prenatal diagnosis, correct termination, correct non-continuation, continuation. So that's how. So thank you, everyone.
Thank you.